Live, ma'am. We can start.
Yeah, I can see the Vice Chancellor. Yeah. Since the Vice Chancellor is there and is our chief guest also online, we have to see. Dr. Nandini, are you there?
Yes, I can see her.
Can we have the video on, please, ma'am? Can we have...
I request Dr. Nandini to put on her video, please. Dr. Nandini, can you hear us?
Dr. Nandini, are you online?
She just said, and it just disappeared. Maybe she has logged out, I'm not sure.
We will have her number also.
Good afternoon, Dr. Animesh.
Good afternoon. Good afternoon, Satish sir. Good afternoon.
Nimesh, good afternoon after a very long time.
Yes, sir. And that too virtually. Yes, sir. Good to see you, sir.
Thank you for accepting our invitation.
Always a pleasure, sir.
Good afternoon, Vice Chancellor, sir. Good afternoon, Dr. Animesh.
Good afternoon. Good afternoon, Dr. Anirban.
Anirban.
Yes, I can see you. Yes, good.
So, Dr. Smita, can we start?
Are we waiting for Dr. Nandini to come on board?
Yes.
Or can I start?
No, I think she was there.
I have contacted Nandini ma'am.
Yeah. She will be online.
I have contacted Nandini ma'am.
I think Dr. Ashok has also joined. Good afternoon, Dr. Ashok. Can we have your video on, please?
Yeah.
A bit.
Good afternoon. Good afternoon, sir.
Good afternoon.
Good afternoon.
Is Dr. Nandini trying to get connected? Anirban?
Thought Krishna Kumar spoke to her just now.
So what is the result?
I'm just getting it.
Yeah. Initially there was some difficulty. Okay. Thank you. Okay.
Okay, Smita, can we start now? Dr. Nandini has come online.
Yes,
Because all
ma'am.
the others are waiting. Yeah. Okay,
Yes.
please begin.
Yeah. A very good afternoon to one and all. Welcome to the 4-day workshop on ethics in biomedical and health research, perception and practice, which will start today and go on till 8th of July 2021. The topic of ethics is very relevant in the current scenario, and it always has been. And it is the evidence lies in the large number of participants we have today at national level who are interested to listen to the eminent guests that we have on the list. So I welcome one and all. To begin with, I have a few housekeeping announcements. I request all participants to keep their videos on and kindly switch off their microphones or audios so that we can see you. And looking at the participants, the speakers will be inspired to speak in a personal approach. And in case you have any technical issues, kindly write your problem on the chat box and it will be attended to. So once again, I welcome you all. I now call upon Professor Dr. Indrani Karunasagar, Director, DST New Tech and Projects, Nitte deemed to be University, to kindly welcome the gathering.
A very good afternoon to all the registrants, the resource persons, and last but not the least, the organizers of this very important workshop. I begin by saying good morning, good afternoon, and good evening, because we have registrants from other parts of the world who are ahead of us and many who are also behind us. And to all in the country, let me extend to you all a very warm welcome. The number of registrants in this workshop, numbering over 850, speaks of the interest in this particular topic of ethics. It would not be out of place to let you know that Nitte deemed to be University, that is one of the recognized centers of the Department of Science and Technology as an enabling center located in the premises of the Nitte University Center for Science, Education and Research, has the task of becoming very relevant to society, not only because we work on translational research projects where all the research done in several laboratories of the country move from the shelves of the library or from their own digital boxes to become important to society. Towards that aim, the center was set up. But in order to have such interdisciplinary projects translated, it is very important to have ethics instilled. Therefore, ethics, which serves as a guide to our daily living, if we have to live in a moral fashion, it helps us judge whether our behavior can be justified. We talk about work ethics, we talk about ethics in society, we talk about ethical concerns to environment and at large the society. So it is in fact the right way of living our daily lives. And it does this by helping us establish rules, principles, values on which we can base our conduct. Now, ethics at every stage is very important. Today's workshop, which is Ethics in Biomedical Research, will be focusing on several aspects related to clinical research, clinical trials, drug trials, vaccine-related research, and of course, not forgetting the basic principles of research through responsible conduct, and the final part, the publication ethics, the project ethics. Now, ethics therefore guides each one of us towards a better living, which enables us to have a better place, which is due to the choices that we make. Now, it is sometimes a gray area. We cannot call ethics as white and black, but we can be using our judgment, decide where we want to be. And for all of this kind of decision, and to steer us out of unjust outcomes towards justice, we have a very eminent panel to lead in today's program. This is a welcome talk, and I gave, of course, a brief about the project itself, the program that is going to be covered in the next 4 days. We have chosen the time according to the convenience of the institution that is involved in conducting it, according to the convenience of other country people who are registered, and I must admit that all of this has been possible through the support that the Vice Chancellor has given us, unstinted support. And therefore, for all the registrants numbering over 850 in today's event, I want to say, welcome. You are the backbone of the event, and the event itself becomes very, very significant when we have a phenomenal number as this, because that reflects the interest that every individual is having towards the issue of ethics. Having said this, why do we have such a large number of registrants? It's not just from medical colleges, universities, science colleges, but also a lot of them from engineering colleges also have registered. This is because the new education policy has, of course, ethics as main concern. And therefore, it is in the fitness of things that a program like this was prepared, and the Department of Science and Technology that has been supporting the Technology Enabling Center wanted us to reach out to those beyond the precincts of Nitte deemed to be university, to other universities in the state, outside of the state, in the country, and I'm really surprised that outside the country registrants have come from the UAE, Nepal, Saudi, Kuwait, Oman, Japan, and Egypt. Well, that is a very, very, I should say, encouraging fact, because it shows the world is coming together to understand ethics, especially at these times when a pandemic has been ruling the world. I would first like to extend my welcome to our Honorable Vice Chancellor, without whom no event can take off, only because his encouragement is there to pep up everyone to do their best to see that the university becomes relevant to humanity as a whole. The Vice Chancellor, I have to introduce, even though we all know him, because there are a large number of registrants from, as I mentioned, the entire country and also from other parts of the world. And therefore, it is only appropriate that I let everyone know that a medical graduate who moved through the rungs of government institutions to acquire his undergraduate and postgraduate degree has a very good track record in otorhinolaryngology, ENT as we call in common parlance. And he joined, of course, the Manipal group of institutions, and after the first formative years, moved to the Nitte group of institutions, particularly the K.S. Hegde Medical Academy, where from the ranks of professor, he moved to become the vice dean, and now occupying the coveted chair of Vice Chancellor. An individual who goes through the steps of this kind of a ladder rung that one climbs has attained all the experience that is necessary to lead an institution. And therefore, with his interest, of course, in his practice work related to ENT, but more importantly in research, he finds ethics is a very important issue. He has also been awarded a degree, the FRCS, and we are very happy that with his interest in research projects, in publications, and today sitting at the helm, encouraging others to publish and have projects, he rightly is the, I should say, backbone behind today's event. He's also the chairperson of the DST Tech of our university, which is the case with all the techs in the country. We have 8 of them, and we are very happy that we were awarded one, which was on a competitive basis. The Institute of Science Education and Research, that has research as the most important component together with teaching. Every teaching program is accompanied by research. Therefore, took up the task to host this particular event. And the Vice Chancellor immediately agreed when it was put forth to him. We are happy that many sister institutions, medical institutions particularly, have all joined, because there are many ancillary institutions like the nursing colleges, the pharmacy colleges, the physiotherapy colleges, which all have to know ethics, not forgetting, of course, the research institutes in the country. Sir, I'm very happy to welcome you to this particular event. I do not have to introduce our panelists because through the flyer, a lot of details have already been circulated, the positions they hold or they held. To lead in this particular program, as the chief guest, we have Dr. Nandini Kumar. She, of course, has been the backbone of ethics, having been associated with the ICMR for many, many years. You will hear a lot about her in due course before her presentation. But what I would like to say is, if you can get a charismatic individual to be the chief guest at an event that everyone is watching and wanting to listen, we scored high because we could get her. And believe me, a simple person that she is, whom I have met and known, she immediately agreed when contacted. Thank you, Dr. Nandini. There will be a lot more in store about you, but this is a formal welcome of mine now. I'm very, very pleased that we have a person of her caliber, an internationally acclaimed person, an observer for the ethical guidelines in many countries. We could not have asked for more. We also have on our panel Dr. Ramchandra. Well, animal ethics occupies a very important place in any ethical concern. And as you see, this event has spread over a very wide area, which includes not just all the ethics related to human trials, human drug trials, any other issues related to human beings, but all of it is usually tested first also on animals, the drug trials. And who else could have been suitable for this than Dr. Ramchandra, who is now the director. Just a month ago, he has taken over as director for the ICMR Center for Animal Resource Facility that is based in Hyderabad. But he continues to also at this moment occupy another chair, which he held for many years, which is as chief scientist at Indian Institute of Science. A veterinary postgraduate in pharmacology, he's traveled far and wide to be where he is now with the knowledge that he has accrued, and he will be there as one of the important speakers. We also have, for vaccine development in trials, another facet where ethics becomes very important. Dr. Subhrojit Bhaumik from Kolkata. He is, of course, presently working with the Peerless Hospitals as the clinical trial analyst, and he occupies also other visiting positions at the University of Birmingham as an honorary lecturer. But apart from this, the government of West Bengal has taken him to help at the technical university there with all aspects related also to clinical research. Homegrown experts are there with us. We have from our neighboring institutions, Manipal University, three strong characters, three strong men who have been leading many institutions in the ethics workshop and training a lot of people, because training becomes the very first step to progress. We have Professor Chakrapani, who is the Director of Ethics at Manipal University. He's also the Professor of Medicine, and with a very, I should say, sound knowledge of ethics. He is also the chair of Nitte deemed to be University Ethical Committee. We also have Dr. Animesh Jain, the Professor of Community Medicine, and Dr. Ashok Shenoy, the Professor of Pharmacology at Manipal University. All the three gentlemen are at Kasturba Medical College, Mangalore, but they have carved a name for themselves and have been supporting many institutions, including ours. And if we stand where we are today, it is because there has been some degree of hand-holding that we got from these gentlemen. Well, all the registrants, you will be eagerly waiting to hear more about this workshop from all of them in the days to come. I should say the hosts for this are, of course, DST Tech, but more importantly, the University Center for Science Education Research. And there are topics related to research that will be presented by the director of the institute, Dr. Anirban. We have the research and patents advisor, Dr. Karuna Sagar, and I will also be speaking on dual research of concern more towards the end of the workshop, because research and publications, which become very important also, will be probably at the end of this workshop to let you see how all the knowledge accrued can be translated into the research publications that you may have for a long time been wanting to do. So I can't say these are few words. There have been a lot of words spoken, but the workshop itself covers very vast areas. And one of the reasons why we have a very large number of registrants could be, of course, the digital forum that enables circulation of such information through social media, and the vast topics that are covered, be it drug trials, be it clinical guidelines, be it research related to vaccines, as I mentioned before, informed consent. What do you do if you want to carry on some research where you feel that you have to overcome all of the patient issues, the patient's party issues, the societal issues, environmental issues? All of this and more will be presented to you by various experts during the next 4 days. So with these words, I would like to thank the Nitte deemed to be university represented by our Vice Chancellor, the opportunity for hosting one, which will be in a series of many workshops related to different topics of, I would say, public concern that will come out in the next few months. Thank you very much. Smita, may I now ask you to introduce our chief guest? We now have the opening remarks by our Honorable Vice Chancellor, following which we will have our chief guest addressing everyone. Over to you, sir, for the most awaited opening remarks for this event.
Thank you, ma'am.
Good afternoon. Thank you, Indrani, for the nice introduction. It's my privilege to be part of this national workshop on Ethics in Biomedical Research and Health Research. Very distinguished resource persons, and the chief guest for this day, Dr. Nandini Kumar, former Director General ICMR, Dr. Ramachandra, Director ICMR, Animal Resource Facility for Biomedical Research, Hyderabad, Professor Dr. Ashok Shanai, Dr. Animesh, Dr. Chakrapani, all are well known to you. They are all good friends of mine. Dr. Subrajyoti Bhaumik, Clinical Director, Fearless Hospital, West Bengal. Dr. Vidya and Dr. Indrani Karunasagar, the directors in our newly established DST New Tech. Professor Anirban, Director of NUPSAR, our Science Education and Biomedical School. Dr. Smita Hegde, the coordinator for this important webinar, and all faculty of Nitte University and students and postgraduates and PhD students, and also the registrants from various parts of India and abroad. It's indeed my privilege to be part of this inaugural function. As Indrani said, Nitte University is well placed to conduct this 4 days very unique workshop with its robust research infrastructure, having one of its kind DST New Tech facility in the university and 6 research centers, state-of-the-art research centers doing biomedical research in the university, state-of-the-art animal house, zebrafish facility, research facility, a unique facility in the university, and our ICMR approved university ethics committee and 3 institutional ethics committees, the constant colleges, and also being the member of UNESCO chair of bioethics HIPAA. Ethics, as you all know, is derived from a Greek word, ethos, means moral. The medical profession is probably the oldest one to prescribe ethical guidelines. The concept ethics dates back to 400 BC by the father of our modern medicine, Hippocrates. But rapid advancement in the whole field of medicine and biomedical sciences have added newer responsibilities and complex dilemmas for both medical practitioners and the researchers. When you go to the background, the history of these ethical issues, several unfortunate incidents which happened in the history haunts us, several unethical, cruel experiments which were conducted maybe by Nazis, by Japanese soldiers, or by Americans during the World War II or before and after World War, led to one of the important trials of the history on ethics. You may be knowing Nuremberg trial and this document which was formed, the code, which was what we call Nuremberg Code. The main theme of this code was we should take voluntary consent of the human subject, and it is very absolutely essential when you are doing some research. Another important document, according to me, is the Belmont report published by US National Commission for the Protection of Human Subjects of Biomedical Research. It also is based on 3 important principles like respect for persons by informed consent, beneficence, risk and benefit evaluation, and the last but not the least, justice. Another important document, which is, I think all of you researchers very well are aware of this important document, published in 1964, Helsinki Declaration, published by World Medical Association, which addresses the international standards primarily for physicians involved in biomedical research, also encourages others to follow the guidelines in doing research using human subjects. Again, in the heart of this declaration is a statement that the well-being of the human subject should take precedence over the interest of the science and society. Our important organization, Indian Council of Medical Research. It has published the ethical guidelines in the year 2006 for biomedical research on human participants, which has got, I understand, got 12 guidelines. Again, the pillar of this guideline is the 4 pillars of bioethics: autonomy, beneficence, non-maleficence, and justice. Again, this is formed respecting the law of the land for when we are conducting observation experimental studies, and it is very specific to our country. And I understand in that declaration, they had included guidelines, they had included stem cell research, genetic studies, and even Ayurvedic formulations. But the latest one, the 2017 ICMR guidelines, it has been formulated to accommodate the rapid changes in the biomedical research and its environment. I understand that the new guidelines includes public health, socio-behavioral research, conduct research during emergencies and disaster, and collaborative research also have been included. It also narrates the details about, as Indrani said, the importance of informed consent, the formation of the ethics committee, and what are the responsibilities of the institutional ethics committees. It is thus very important that every stakeholder, whether a researcher or a member of ethics committee or a sponsor, is aware of the provisions of the ICMR guidelines and would help to improve the biomedical research in India. I understand that, as Indrani said, more than 800 or delegates have registered for this important bioethics workshop. I understand medical, engineering, and several universities and its constituent colleges, faculty and students have registered for this workshop. With the implementation of, as Indrani said, new education policy, it has become more important with the importance given to research. Ethics has become very important. The importance of this program arises from the fact that this workshop has included many interesting topics like clinical issues pertaining to the research, clinical trials, vaccine development, device development, handling of animals and including drug trials, responsible conduct of research, ethics in publication, and several other bioethical aspects. In this context, this workshop has brought together several eminent international and national experts to speak to you directly, even though it's in a virtual format because of the pandemic situation. Hearing directly from this expert will be really very interesting, and you can clarify your doubts in the end by sending your queries to the respective persons, and definitely it will add to your knowledge regarding conducting bioethical research, ethical research in your institutions. I once again congratulate Nitte University, DST New Tech for organizing this 4 days workshop. I hope all of you will carry very pleasant memories of this for this 4 days workshop. I thank the distinguished resource persons who accepted our invitation to participate in this workshop. Thank you very much, and wish you all the best. Thank you very much to all the participants who are registered for this 4 days workshop. Stay safe, stay healthy during this unprecedented situation. Thank you very much.
Thank you very much, sir. Being a leader of bioethics in Nitte deemed to be university, it is only appropriate that you were there here today available to be the president of this workshop that is going on. I now request Dr. Smita to introduce our chief guest to the audience. Smita, are you there? Yeah.
Yes, ma'am. It's indeed a pleasure to introduce such a distinguished lady to the gathering. Dr. Nandini graduated from Trivandrum Medical College, and she has been an eminent clinical pathologist. She has her master's in ethics from University of Toronto, Canada, as Fogarty. She was involved in medical research, gastroenterology department in Trivandrum at Madras Medical College, in charge of liver clinic in General Hospital, Chennai. She retired as Deputy Director General from ICMR, New Delhi, where she was the Program Officer for Bioethics, Traditional Medicine, and also for some time for Pharmacology and Summer Studentship for Medical Undergraduate. She was closely involved in activities related to drug development in traditional medicines, which is the backbone of India's traditional herbal medicine system. So she has a very active role in formulation of different national ethic guidelines, particularly for the Ayush, in formulations, in stem cells, drafting guidelines on mental health, data set protection, disaster-related research, and HIV and AIDS. She has been closely involved in finalizing the ICMR ethical guidelines of 2006, and the 2006 session, she was in charge of finalizing the guidelines, and she was a member in 2017 as well. She was closely involved in preparation of the bill of ethical guidelines involving human participants from 2002 to 2007. And she is a national and international surveyor for the Strategic Initiative for Development of Capacity in Ethical Reviews, which is a WHO initiative for recognition of ethical committees. She's a pioneer in the area of bioethics education in India, and having started the first online diploma program in bioethics under ICMR IGNO joint initiative through NIH funding. Her expertise is in the area of bioethics and traditional medicine as well. She has several publications to her credit and has actively involved herself in government and pharma industry initiatives in promoting awareness about protection of human participants and recent regulations of clinical trials. She's a member of several technical committees which review pharma proposals in CDSCO. She's a member of international panel of President Obama's Commission for Study of Ethical Issues, besides other national and international bodies. She was the Dr. TMA Pai Endowment Chair for Bioethics in Mahe and is presently an adjunct faculty in several institutes. At present, she is a consultant for bioethical and traditional medicine research and vice president of the Forum of Ethics Review Committees in India, a national chapter of the Forum of Ethics Review Committees, Asia Pacific region. She was awarded the Outstanding International Ethics Committee Surveyor in 2019. And presently, she is the member of ICMR's Ethics Advisory Committee in the Nitte Aayog, and also the chairperson of DSMB, that is the Data and Safety Management Board for COVID-19 research on Ayush formulations. It's indeed a pleasure to have you, ma'am, amongst us. And I now call upon you to present your talk to this August gathering. Welcome, ma'am.
Namaskar to everyone. It's actually an honor and privilege to be, invited to give this talk, and I address the Vice Chancellor, Dr. Satish Kumar Bhandari, to actually register my apologies for appearing late in this program, not at 2 o'clock, but 5 minutes later. And also to all the dignitaries and ladies and gentlemen, what I'm going to talk today is only a complimentary presentation from what the Vice Chancellor has already described about ethics. And when we talk about ethics in India, in fact, we should not forget that we have a rich heritage from our traditional medical systems, which were centuries ago. They had actually dictated what should be done by a physician in circumstances where he has to look after a patient. I'm talking about he because there were not many she's at that time. And the thing is that those days, what they had prescribed were actually relevant to research also, because there are centuries of research, observation, etc., which led to the what you call the formulation of the practice guidelines. So when we talk of modern medicine, it's only about less than 300 years old. So when we are actually talking about the Western principles being borrowed from there and then expanding it, we should not forget that we already had these principles earlier. Of course, it was a patriarchal society, so those norms may not hold good today. So shall I actually start my presentation?
Yes, ma'am, please do.
Okay, so actually our Vice Chancellor had already told you that there are these 4 principles which are brought out in the Belmont report. And I would like to state that the 4 principles were the basis for having the 12 principles, general principles that we have in the ICMR guidelines. They were the same when it was in 2000, the first revision. In fact, the first guidelines we had in 1980, which was only 8 pages, short paragraphs on very important issues, actually. But that needed to be expanded because of the development of science and technology. It took almost 20 years to bring out the first revision. And then, of course, the second revision in 2006, and then 2017 again was a big process. So here we had actually changed, I mean, the first and the second revision had almost the same type of ethical the general principles. And these general principles were, this was, I mean, each chapter was given to a separate committee, but the general principles was given to a lawyer. So the language there was much alike what lawyers speak. So it was a little difficult for people to understand the intricacies of what was described there. So in 2017, it was made more readable, more understandable with simple sentences. And we also changed the 3 principles that were there earlier in 2000, 2006 into bringing in the social responsibility and also increasing the emphasis on benefits and also the environment. Environment is very much a part of UNESCO mandate besides ethics. And this environment part was actually included in the first general principles or principle of essentiality. Now, that has been brought out as a separate general principles because of the importance that we have, and especially when we are talking about science and technology, we talk about nanotechnology and other developments, the new technologies that are coming up, which actually lead to some pollution of the environment. How do we take care of that? So that's why it was brought out as a separate principle. Then before I'm going to actually make a different sort of presentation from the usual one. I hope you'll be able to understand that and maybe you may enjoy it, but I don't know, with the virtual phenomenon happening these days, the interaction may not be that very nice as we may expect. But I suppose Smita or somebody else may help me if there is something in the chat box to guide me. So starting with my first slide, we should first understand, because my topic is on academic research, snippets from academic research. So the regulators actually have divided clinical trials into 2 types. One which comes under their purview, which is called clinical trials, and the other which doesn't come under their purview, they call it academic trials. Now, along with this academic trial, the biomedical and health research also gets tagged along. So you have one requirement for clinical trials that is a regulatory in nature, and the other one for academic or BHR is biomedical and health research. Now, when we talk about this, let me first introduce you to what is academic clinical trials. Although Shania also may be presenting this, it's just a sensitization. So here, what we do is we actually take the marketed drugs. These are not new drugs, they are already marketed. And with that, you want to do a research. And that research may be to find a new indication. For example, if it is marketed for, say, as a skin ointment, and now you want to test it in mucosa. So then you will have that as a new indication. New route of administration. Instead of having the parenteral route, you can have oral route. So that is also another new development. And then those also can be different. From 25, you want to test and see whether 50 will do, or even lesser than that. And the dosage form, you may have pill, and now you want to use sachet. So all these are there, but remember, they are all marketed drugs, and it's purely for academic purpose. So here only EC approval is required. You don't require DCGI approval. And the compensation involved when carrying out such research will be actually as per ICMR ethical guidelines. Because when you have the new drug, which is under regulation, then you have to actually give the compensation as per CDSCO rules. So new drug and clinical trial rules, which Shanoy will be talking about. Now here, ICMR ethical, that is actually well laid out. There was a lot of hue and cry initially from the industry, but now everybody has settled down, and they have realized that it is not so much of money as they anticipated as compensation. And they have a formula, etc. for that. But for the academic or biomedical research, ICMR guidelines are still gray. Gray in the sense that it is left on flexible grounds. For example, you may have the institution actually plays a big role here, because the institution will have to provide either group insurance, or it will have to create a corpus to meet the demand of a compensation. And then if the investigator, for investigator-initiated research, if the investigator writes for a grant, then in that case, the investigator can have a separate head for compensation. Now, if there is an overlap, the ethics committee feels that, no, I think we should get the opinion of the licensing authority, DCGI. So the DCGI is informed about it, and the DCGI has to give an approval within 30 days. That is no objection certificate. And if it doesn't come, it is deemed as approved. So now the definition that is given for biomedical and health research is studies on basic, applied, and operational research designed primarily to increase the scientific knowledge about diseases and conditions, whether they are physical or social behavioral, their detection, cause, and evolving strategies for health promotion, prevention, or amelioration of disease and rehabilitation, including clinical research. So there's a difference between studies, the clinical trials and clinical research. They are not synonymous. Clinical research is the wide umbrella which has all types of research under it, whereas clinical trial is a part of that. We'll come to that later. Now, in the rules, the same definition has been taken up to this point, rehabilitation. And then it says, but does not include clinical trial as defined in clause J. So the clause J, what is written is about new indication, new route, and all those things which Shanoy will be describing in detail. So J is pertaining to the regulatory clinical trials. So if it is not a regulatory clinical trial, the regulators actually accept the same definition as it is given in the ICMR guidelines. Now, we'll go straight into the types of risks, because what I am going to ask you has this as a background. So what are the types of risks? There are 4 types which have been described. Till 2006, we only talked about less than minimal risk, and more than minimal risk. Minor increase over minimal risk has made a new entry in this guideline. This is at par with the international, terminology that they are using, including SIOM's guidelines. SIOM's guidelines is a guideline which is made in collaboration with WHO and is expected to be followed by all countries if they don't have their own national guidelines. So I must say that the ICMR guidelines is based on international documents, but it has been actually molded according to our requirements wherever necessary. So here what we see is actually the 4 types of risks. And I would like to actually mention that minimal risk is probably the benchmark. So anything below this has a significance, anything including this has another significance. Let's see what that is. So when we say less than minimal risk, I told you minimal risk is the benchmark. When we say less than minimal risk, it has to be research on information which does not identify a person. Very simple to understand. So whether it is data, whether it is something else, which does not identify. So you have, on public domain, you have information. You have so many types of research where you're not identifying a person. You are actually looking into details about what a program is. So that does not identify a person. So always remember, what is not identifiable, that becomes less than minimal risk. Why is this identity so important? Because you are actually getting into the privacy and confidentiality of an individual. So that actually leads to a lot of responsibilities. But when you are not touching that person at all, then it is called less than minimal risk. Now, what is minimal risk? Minimal risk is what you may encounter in daily life. Very simply stated. There are tails to that, which is there in the ICMR guidelines. I will not describe that. And the Americans who actually defined it first also have certain, other sentences coming along. But suffice to know that what we encounter in daily life, what we may encounter in daily life is called minimal risk. For example, you are just walking along. There's every chance that you may hit your foot against a rock or a stone, something like that, which is expected. So that sort of risk is called minimal risk. Now, so these 3 actually identify the person. So minimal risk is daily routine, but now there's more invasiveness. What is this invasiveness? There's a scale there. At one end, you have minor minor increase over minimal risk, that is of low risk. On the other side of the scale, you have high risk. So you have stent, you have research on stent or other appliance, applicable apps and things like that. And also psychosocial, risk, vulnerable population. They are at a vulnerable position. So you may cause a lot of harm to them. So such proposals will always be more than minimal risk. Then what is minor? Minor is like, for example, you are taking blood, 5 ml of blood from a healthy individual. So there is invasiveness here. So you have taken the blood, it's 5 ml only, and the people are healthy. That will be termed as minor increase over minimal risk. There are other instances also, which are actually highlighted in the ICMR guidelines. I'll not go into detail about that. Suffice to know that comparatively the risk is low, and then it is called minor increase over this risk. And the more invasive it is, it becomes more than minimal risk. Having laid this background, this will help you in answering questions which I will be asking you later. So what are the types of risk? Why do we actually classify these risks? Why is it important? Because if it is less than minimal risk, you can exempt that from review. When you say exempt that from review, the investigator cannot actually decide, oh, my project is based on whatever is there on the public domain. Why should I go to the ethics committee for approval? Problem is, sometimes some of the journals will ask you, where is the ethics committee certificate for exemption? Then you can't run back to the ethics committee and ask for it. So a researcher doesn't decide what is to be done with the project. Any research project for that matter has to come to the ethics committee secretariat. So the secretariat can issue a letter saying that this proposal is exempt from review. And who decides that? The member secretary. Sometimes the member secretary may also be in doubt, and that member secretary can consult with the chairperson and exempt it from review, sorry. Then we came to the next one, minimal risk. Now, it is no more than minimal risk. No more than minimal risk means if it is more, it can be minor increase or it can be more. So minimal risk. So here, of course, you have the identifiable data. There are certain types of proposals which will not need that much of elaborate review by all the committee members. A small committee can actually decide that. And that is called expedited review. Now, full committee always, as I told you, all minor increase over minimal risk as well as more than minimal risk will come to full committee. Then why did we have to divide this into minor increase and then more than minimal? It is because the ethics committee will have to decide what type of safeguard it will like to have. For minor increase over minimal risk, they will say, okay, you submit your progress report annually. But when it is more than minimal risk, it will say, please submit your research 3 monthly or 6 monthly and so on. And COVID, the research is very much an example of that. Also, I would like to tell that the vulnerable population, whenever you have a project on vulnerable population, even if it may be of minimal risk, it has to come to full committee. That is the exception. So having that in place, you also would like to know who can be the principal investigator. Now, we have to follow the GCP guidelines with regard to this. ICH GCP, I have actually forgotten to put ICH here because we also have Indian GCP, which has become quite obsolete now. And the new one, the revised one is actually being looked at. It may come out anytime. Once probably the controller gets out of the tangles of the COVID issues. So ICH GCP E6 has this 7th and 8th principle which bind the professional who is becoming the investigator. And what is that? The 7th principle says that why do you need a qualified physician or a qualified dentist? Is because they will know how to treat the patient, because the patient can have other problems as well. So it is the responsibility of a qualified physician or a qualified dentist to take care of that. So the medical care is very, very necessary. And who should give that medical care? That person should be qualified by education, training, and experience. Why I'm stressing on this is that education is important. Okay, you are MBBS or you are a dental degree, but you are only MBBS. There is no training, there is no experience. Now you have become a postgraduate. So you are qualified by education, fine. But you don't have training, you don't have experience. Okay, so that's why people generally have, the postgraduate students may have some training, but no experience. So you will require at least 2 years of experience after having postgraduated to qualify you as a principal investigator. So that principal investigator term is very, very important. That principal investigator has to give the proper medical care if needed, and also be qualified by education, training, and experience. That's why the regulators actually say that in the ethics committee, the experts, the scientists who are experts should be qualified, no doubt, but also should have 2 years of experience. So a fresh postgraduate cannot become a member of the ethics committee. There has to be prior experience. Keep these also in your mind. When you talk about research, there are several stakeholders. On one hand, you have the sponsors, the CROs, and then you have the investigator and the site staff directly interacting with the patient. Then you have the ethics committee, which protects the patient through instructions to the investigator, and then the regulatory authority, which can enter anywhere. It can actually see how you are taking the informed consent. It can go to the IEC to see how the documents are kept, how are you actually functioning. And it can also see whether the investigator is appropriate or not. And it can also examine the documents at the CRO office or the sponsors. So the regulator goes to everyone. Here, I'll be talking only about investigator and IEC. So let's go to the first title. So I will actually give you titles of some proposal. So factors related to anemia and iron status among pregnant women in urban city M. So this is the proposal. Now the PI wants to actually have 2 more sites added. So this has been approved. Okay. Now the PI comes and says that there are 2 more sites to be added. So the previous review was done by the full committee. I would like to ask why it was full committee. It could have been actually, it's a very simple thing. Anemia and iron status is not very big deal. But why did the full committee see that? Any answers?
Yeah, because you have, ma'am, can I speak?
Yeah, I saw the, are you Swati?
No, I'm Fatima.
Okay, anyway,
Because
you have given the good answer, vulnerable population. Very good. Very good that you have picked it up. Okay, pregnant women. So as I told you, it may be in the minimal risk category, but if it is vulnerable population that you are going to access, then it comes to the full committee. Okay, so previously it was seen by a full committee. Now, adding 2 more sites, what is the magnitude and probability of risk involved? I told you about the risk, I told you about minimal risk, minor increase over minimal risk, and major, more than minimal risk, less than minimal risk. So where will this fit now? Adding 2 more sites. Remember, it has been seen by the full committee, okay? Yeah. So somebody said low risk. So low risk means you meant minor increase over minimal risk, is it? And there's a good thing like a different population, fine. That is a good point actually. Okay, now this different population is, again, you have pregnant women only there. No? So pregnant women may not have much difference between populations except for the cultural aspects. Okay, so the ethics committee would like to see where are these two sites. It's very good. Shishir has actually written that. Shishir also writes, could be high risk, principle of justice and access to care may be different, but you are supposed to take care of that. So it has to be uniform care, uniform principles to be applied at all sites. So that is not an argument, but see, the point that Shishir had was that they may be a different population. So you will actually inquire, where is this? Is it in a rural area? Is it in remote area? So if it is in remote area, then you will have to say, how will you go? How will you access? Who will help you? And then suppose that site, the population speaks a different language, then are you going to have an interpreter and all that? So you will ask all that. But suppose I say that the population is the same type. So in that case, what will be this risk? It will be the same type of risk, isn't it? So already the full committee has approved. Now the only additional factor is 2 sites have to be added. Risk is the same, people are the same. Okay, so it can go for expedited review because the risk is not more. And you have already reviewed that. Okay, so it can go into expedited review. As it is also, minimal risk would go into expedited review. But just because of this pregnant women population, it went for full committee. Now you, by adding 2 sites which are similar in nature, you are not increasing the risk. So it can go for expedited review. Okay. Now to the next one. So here, the role of genomic biomarkers in predicting prophylactic response to lithium in pediatric onset bipolar disorders. So lithium you use in bipolar disorders. Now here the investigators are one from psychiatry, one from clinical pharmacology, one from pharmacology. And an amendment is requested for change of co-investigator from Department of Pharmacology. So this, this PI and this co-PI is going to change. So that is a simple request. But tell me whether this request is justified. Fastest finger. Yes or no? Yes? Yes. Okay. If so, what type of review is required? So amendment, changing the PI. Okay. So what type of review? Just imagine about the risk. Is the risk high? Higher from what you have already seen and approved. Adding another PI, does it increase the risk? So somebody wrote expedited, somebody wrote exemption. Why did you write exemption? You're identifying people here. You can't say exemption. Okay. So identification is very important to say that it cannot go under exemption. Whereas here, again, I told you, like in the previous one, is there any additional risk? If not, then it goes into expedited review. Okay. Full committee review. Somebody has written full committee review. Okay. The first time, because again, you have a vulnerable population here. First time, the proposal was seen by the full committee. Now, the request is only for the co-investigator change. Now, if the co-investigator is changed, does it increase the risk? you will have to see from the CV. The CV is satisfactory. This person is actually qualified to be a co-I. Because if the person, pharmacology person has done something in neurology, then qualified. Or the co-I, which is going to, who is going to replace this Dr. AS, is also a specialist in neurology. So there's no problem, there's no risk. So it will go into expedited review. Now my question is whether the co-investigators are appropriate. Yes or no? Yes. What is lacking there? So you have the department of psychiatry. So bipolar disorder, psychiatrist is there. Clinical pharmacology, it's a study, good. Pharmacology, they are genomic biomarkers. Pharmacologists can also do genetic studies. What is lacking? Pediatrician, Josmita, Audrey DeCruz, all of you, Swati, all of you have got the point. Very good, very good. Okay, next one. Prevalence and risk factors of Clostridium difficile infection in patients with hospital-acquired diarrhea in the institution, a cross-sectional analytic study. Okay, Clostridium difficile is supposed to cause diarrhea. Okay, now the principal investigator is a junior resident. Guide is in microbiology. I mean, they are all from microbiology. Then one person is from pediatrics. One is from Department of Medicine. One is from Department of Medical Oncology. So my question is, can Dr. R.K., the junior resident, be a principal investigator? Yes, so you have got the point, no. Okay, so he is still not qualified to be the principal investigator. So what will be his designation? What designation would you like to give this person? He can't be co-investigator because co-investigator also has the same has to have the same qualification as the PI. Yes, Ananda Krishna, you are right. The person will be called student researcher. Okay, if you want to keep researcher, that's fine. But it is better if you say student researcher. That distinguishes. But the guide is supposed to give an undertaking that everything will be done under his or her supervision. So are the co-investigators appropriate here? If not, who is the person who is not appropriate? Who is not appropriate? Medical oncologist. Very good, very good, very good. I am very happy. So you've got the point. So now this is big title. Okay. A multi-center 3 arms open label randomized study to compare the efficacy and safety of marketed products of nanosomal drug A lipid suspension to drug A injection concentrate in triple negative breast cancer patients. Okay, quorum is satisfactory. Now legal expert is absent. What is the minimum quorum requirement? Nobody knows the minimum quorum? 5, good. 5 is the number. Okay. So they say EC quorum is satisfactory. So they must be having 5 people. More than 5 also you can have. Okay. But minimum is 5. Legal expert is absent. So can the EC take a decision on this proposal? Can the EC take a decision. Why no? Why is it no? Look at the title. I said marketed products. So that is the catch. Okay. So when you say marketed product, what does it become? Does it become a regulatory trial or a non-regulatory trial? Say academic or biomedical research, whatever you may call it. Marketed product. So does it make a change? So it becomes academic. So in academic review, legal expert is absent. Is it okay? Is it okay if the legal expert is not there?
No.
Not okay? Okay. So this is a point of discussion. I am pointing out to this marketed product. When it comes to marketed product, it becomes academic in nature. Okay, now we are getting answers. Okay. Can anybody tell me why? Yes? Are you trying? It's already given a license. Good. But then legal expert being absent is okay. That also you have answered yes. But why is it okay? It's not because there's no legal issue. Because when we talk of academic review, we just insist on the number of people forming the quorum. That is not qualified. Okay. But when you have a regulatory clinical trial, then the quorum is qualified. You definitely will have to have legal expert. The 5 people who are there in the quorum are specific people. And therefore, absence of any one of that will make your review null and void. But here we are talking about academic research. Okay. When it comes to academic research, any 5 will do. There's no necessity for the legal expert to be there. Layperson may not be there, or social scientist may not be there. So that doesn't matter in academic research. Now the next one. Now this is registry. Registry for SARS-CoV-2, COVID-19 patients to create a clinical data bank by retrospective consolidation of clinical data of COVID-19 patients. PAN institution. Now you have, the chain of hospitals. You have for Apollo, you have for Fortis, you have Global Health. There are actually chain of hospitals now. So in one such institution, they were trying to get the data from across their different sites. So the list of documents that were submitted on always see the date, okay, 21/6/2021. That means June, last month. Okay. Now, amended protocol, what they submitted was amended protocol version number 1.2. We always have a habit of not writing the version number and the date. And this will be illustrating to you the necessity to do that. The 1.2 dated 27 August. Now, last year. Amended case report form also was having a different version, and this was changed. August. Previous submission June on 27th August. Previous submission approval letter was issued on 17th August. So it was only after the approval letter was given, this amendment was done to protocol as well as to the case report form. Remember, the meeting was on 18th June. And the approval letter was issued on 17th August, because only after that you can initiate the changes, whatever have been asked for. So they have done it accordingly. Now EC has commented on both at the present meeting. It has commented on both and approved the amendments. So now, what should be the amended protocol version number and date? Say the meeting has happened today, or maybe last week. We can have it last week. So what will be the protocol version number and date? Say if I say 30th June, version number 3, date 28th August. Okay, you have gone forward. You have given time for the PI to make the changes. Good. Date should be meeting date. No, it cannot be meeting date, because the EC has to issue the approval letter. So what will be the version here? And it's a minor version. There's a difference between major version, major amendment and minor amendment. If it is a minor amendment, then only this will change. If it's a major amendment, then it will become version 2. Okay, so having heard this, what will be the number for this? I say it's a minor change that was advised. So case report form will be 1 point. Everybody is writing 1.3. How did it jump to 1.3? Here it is 1.1. Yes, 1.2. Shishir Kumar, good. So now we have the lung cancer. Multiple studies involving same patient. Now listen to this very, very carefully, because this is actually happening in many institutions. Now, Dr. S is PI of 3 projects. Very, very natural. With coverage of different aspects, but same topic. Okay, the same topic means it's lung cancer. Okay, we will not bother about what type of cancer it is. On that, different aspects are being covered as 3 different projects. But this doctor is also co-PI for PG projects from Department of Biochemistry, Department of Genetics, Department of Community Medicine. So biochemistry may be to see the biochemical changes in lung cancer, prognosis, whatever it is. The genetics department must be coming, what type of genetic susceptibility this person has and things like that. The community medicine person will come and see how the person is actually getting along in the ward, and about family relations and things like that. So this will be mostly a questionnaire, mostly. But these 2 will be drawing blood. And these 3 projects also will be involving drawing of blood and other invasive techniques. There may be X-rays, there may be CT scan, and so on. So in short, this involves the same patient for 6 projects. What is this position called from patient's perspective? Or let me make it easier. So the thing is, I'll just finish. This is the last one. So the point is, this is called co-enrollment. So the same patient is being subjected to so many blood draws. Okay, so total amount will be too much, and the person is the lung cancer person already, having lesser weight and so many difficulties. So how can ethics committee protect the participant? Is by asking the ethics committee to actually, by submitting to ethics committee, how many proposals is the PI having as PI and as co-PI. So that will give an idea to the ethics committee to reject his proposal in future. Okay. And I think with that, I will close. Wherever the art of medicine is loved, there is also a love of humanity. Sorry if I have actually overstepped my time. Next speaker has to finish.
Thank you so much, Dr. Nandini Kumar. I think the talk was very self-explanatory, simple, and very comprehensive, and our participants were very, very interactive as well. So I can see the chat box rolling. Thank you so much for getting the whole thing rolling. We will keep the question answer session towards the end. I have a small announcement before I proceed on to the next session. There will be a feedback form that will be circulated at the end of every day. Kindly listen. There will be a feedback form. A link for the feedback form will be given every day after the workshop, and you are expected to fill that up. And there will be one posted workshop assessment that will be there at the end of the 4th day. So the assessment is only after the workshop of the 4-day is completed. So this is the announcement. And now we move on. Thank you so much, Nandini ma'am. We now move on to the next speaker, Dr. Animesh Jain. And it's a privilege to introduce Dr. Animesh Jain, who is a close associate of Dr. Nandini to this panel. He's a MD Community Medicine, DFH, PGA, PSG FIMER Fellow of 2008, ACME 2015, PG Diploma in Bioethics and Medical Ethics. He is the Professor of the Community Medicine KMC Mangalore, Head of Mangalore Unit International Chair in Bioethics, Deputy Coordinator, Medical Education Unit KMC Mangalore, Advisor Mahe Students Research Forum KMC Mangalore. He has been very innovative, and we will experience the same when we listen to his lecture. He is a winner or an awardee of Best Innovative Teaching in Community Medicine in 2019. He was a faculty at FIMER Regional Institute, Coimbatore and Manipal, India, an honorary secretary of IMA Mangalore, and a member of several prominent associations and committees here. And his social concerns are very evident. A Rotarian, as a traveler, a photography hobbyist, a philatelist, and he describes himself as a go-getter. It's indeed a privilege to have you amongst us. Over to you, Dr. Animesh Jain. Welcome.
Thank you, Dr. Smita. I hope I'm audible and my slide is already on the screen. Kindly
Yes.
confirm.
Yes,
Thank
sir.
you. Thank you so much.
Yeah.
And first and foremost, I would like to thank Nitte University and the organizers for giving me this opportunity. It was wonderful listening to Nandini ma'am as usual. Thank you so much, ma'am. And in fact, it was again very nice to see those case studies. I am going to touch on some of these, but what I thought is, since you were talking, I have just cut down on a few. It helps me actually to go with my slides now. And good to know that you have covered a few things like risk and other things. So I will just run you through the ICMR guidelines 2017, which came into force in October 2017. So these have been there from 2017. These replaced the earlier ones. The earlier ones were different times, but the last one was 2006. And this replaces that. This is available online, and I would really strongly recommend all the participants to actually download a copy and keep it in PDF for your ready reference. I keep going back to this document again and again when there is a doubt, and I feel that this is a very good document. It simplifies many things, makes it easy to understand, and this particular document over the last one I think is an improvement, because this gives you a lot of things, and I'll just run you through that, and I will just tell you what are the things which are there. Of course, I have a limited time, so what I will be doing is I'll just give you an overview of the whole thing and touch on a few important aspects. Then probably some other time, or maybe as we progress with the workshop, there are other segments which will touch on and give you a little more idea on so many other aspects as well. So these guidelines, as I said, came into force and in 2017. And if you see, this is what Dr. Soumya Swaminathan, who was earlier the DG ICMR and then currently with the WHO, wrote, that this has given us so many things which have addressed concerns about public health research, even disastrous and emergency related research, behavioral, social behavioral research, and even some research which deals with vulnerable population and collaborative research as well. So some guidance is there now in these guidelines, which was always missing earlier. So there was hardly anything, and now these guidelines become very comprehensive. Now, what do these guidelines apply to? So these guidelines apply to all the research which is done in India, which pertains to any kind of biomedical, social, behavioral science research, which is done on human participants. Now, when I say human participants, it could be human participants as participants and they taking part to give us some information, or it could be their biological material or even their data. And what do I mean by that is the data which is already there present with us. It could be in the form of case records, it could be files. So any of the things, all these come under this purview of these guidelines. Now, they've also said that purpose of any research which is done in such a way, they should have these particular characteristics. What are these? So we should definitely try to enhance knowledge about the human condition. However, we should keep in mind the sensitivity towards the Indian cultural, social, and natural environment. And this is very important. When we talk of ethics, ethics has to also look at the cultural context, the environmental and the social context where it is being applied. So something which works in some other place may not work here. Some of the cultural factors are very different here compared to the other places. Similarly, when we do research, we should not do it just that, yes, I want to make it better, or it's going to be advancement of science. So it's not that we are going to use persons or the participants as a means for betterment of others. So that cannot happen. That becomes exploitation, and that is again cautioned there. And one very important thing is that any research which is done in such a way, this has to be subjected to evaluation at all stages. That means right from the design, the conduct, as well as the reporting. And that's where you see this workshop spans on all these things, including about the conduct of the research, the reporting where the publication and other things are there. There is also a thing about a session, if I remember, on the last day is about dual benefit and dual nature research. So this is the kind of structure. The ICMR guidelines are laid down in 12 sections. Each of the section is sequentially numbered, and each of the section contains subsections. Now, how does it help? Because if I want to refer to say 4.3, I know what I'm referring to, and if I convey it to somebody, 4.3 is exactly the place where he or she will land up. So there's no confusion at all. They've also added two sections. One is on responsible conduct of research, RCR, which has been a big thing, especially in the West and also in some countries in Southeast Asia. We never had a formal, document. Now that's come in, at least in some way. Also, we have a section that is 9th section, which is on social behavioral research. And it is neatly laid with boxes, tables, which makes it for easy reading, reference, quick kind of, getting back and then understanding things. And this is, again, just an overview to show you that how these are list of tables, some of these list of tables. So you can see the categories of risk, what ma'am was talking about, the types of review which she referred to, exempted and others. So many things.
These particular aims we have submitted.
I request the participants to kindly mute themselves. I request the participants to kindly mute themselves. The admin may kindly help.
5 years ago,
so the recent, so we know that there have been the age-old principles, that is principles of autonomy, beneficence, non-maleficence, and justice, which have been there and which still hold good. However, in the ICMR guidelines, we have now the 12 principles which have been laid down. And the first principle being the principle of essentiality. So that means they say that if at all we have to do any research using human participants, there should be a justification. There should be a justification that this has to be done on human beings. And who will justify? Not me as an investigator, not me as a researcher, but it has to be vetted duly by the ethics committee. So when I do that research, I should justify that yes, human beings must take part in this research, and this is the justification which has to go through the ethics committee, and they will vet it, and then only we go through this research, proceed with this research. Next thing is about very similar to autonomy. This is voluntariness. So here we have to respect the right of the participants, whether he or she agrees to participate or wants to withdraw. If it's an ongoing research, any point in time, they should be allowed to do that. And the safeguard for this is informed consent. So that's a process, and we will see that tomorrow in a session on informed consent, where we'll look at how exactly this is a process and what are the safeguards available. The third principle is principle of non-exploitation. Now, this means that we cannot just exploit people for our research. We need to make sure that everybody is protected, and there has to be an increased or enhanced protection for the vulnerable. There has to be an equitable selection. That means when I select subjects, I cannot overburden a particular population, or I cannot be a little favoritism shown towards some other group of people. So that has to be equitably selected. Principle of social responsibility. So when we do research, we have to be mindful that our research should not in any way disturb the social and the communal harmony, community relationships. And that is the reason why sometimes the ethics committee will look up and look at the proposals closely. And there have been instances where they've said, in our own institution, they've said, in this particular instance, I don't think there is a role for religion. How does it matter? Like, is it something which is going to, or sometimes we might be suggested some other things, because they know that, yes, this may not be useful. And if there is no justification, that may in fact create some rifts. And we do not want to have more divisions or some kind of social disharmony. There is a principle of ensuring privacy and confidentiality. So let me just elaborate a bit. Privacy pertains to what I would offer to, or if the person who's getting in as a participant, if that person wants to part with that information or wants to share something or is up for getting examined. So that's privacy which is to be afforded. However, once I have the data or I have the information as a researcher, it's my duty to keep that safe and should not be just let out to anybody and everybody. It has to be confidential. So how do I keep that data safeguarded? That's confidentiality. So in other words, confidentiality pertains to data, CD, and privacy pertains to person, that is PP. Now, only in certain situations, including some of the legal conditions where it can be breached, the confidentiality generally cannot be breached. The confidentiality is the duty of the researcher and the investigation team, and they have to ensure that that is always kept sacrosanct. So that is again something which has to be kept in mind. Next principle is the principle of risk minimization. So this is a duty of everybody, all stakeholders, whether it's a participant, researcher, ethics committee, everybody. Now, how do we do that? So we have to have inbuilt mechanisms. Participants should be aware of their rights, what they are getting into. The researcher has to ensure participants are protected. The ethics committee has to go through the proposal and flag anything that they can find. So that way risk can be minimized. And if at all there is a harm, any kind of harm, there should be a compensation and definitely care has to be given. Similarly, there is a principle of maximization of benefit. So here they talk about that there has to be some way where we try to maximize the benefit. While we minimize the risk, we also should give as much as benefit as possible. It should be maximizing the benefit of the research participants. And of course, when we get the results, that also should translate it to the benefit given back to them as well as to the society. Principle of professional competence. Ma'am talked about this, that who can be, and she talked about postgraduate cannot immediately become. So again, here, the people who are taking up research, they should be competent enough. They should have relevant qualification, experience, as well as training, which is appropriate for the conduct of the study. So that has to be taken care of. And most of the times when institutions are getting involved, so what this suggests is the institutions should have policies in place, there should be arrangements, there should be a proper research governance. And that is one of the reasons, if you see, some of the institutions keep getting into these research grants and again, and some of them are because they have a track record, they have systems in place, so that is also important. It includes infrastructure, manpower, even funds and training opportunities. I would suggest, that all the institutions should look at this, and training opportunities like this, what the Nitte University is doing, is one of the examples how you build capacity. Principle of transparency and accountability. Now here, what is expected is that whatever research is being done, there should be transparency in this. And also, it should be brought to the public domain as far as possible. However, the breach of confidentiality is not part of this. So that's something which has to be always safeguarded. The conflict of interest, which I'll discuss in one of the few slides next time in this presentation, I would talk about it, so I'll come back to that. However, integrity, honesty, all those values are very, very important and integral. Principle of totality of responsibility. Now, all stakeholders are responsible. It's not that only the researcher has to be. So everybody is responsible. And the professional, social, and moral responsibilities are binding on everybody. And very importantly, since we are supposed to be environment friendly, so there is a clause which is there now. There is a principle of environmental protection. So researchers should try and minimize the harm that could be done to the environment, whether it is conservation of resources, in doing things, whichever way. So there should be some thought given to that, and we should try and minimize the harm to be done to the environment and ensure that there is protection of the environment and resources. So let me move on to some of the general ethical principles and ethical issues, which ethical principles I've already talked about. Now, any research which is done, there may be some risk, minimal risk or less than minimal risk, but there may be risk. Now, whatever risk is there inherent in that particular research, that should justify the social and scientific value of the research, should justify that that risk is worth taking. And as I've already said, researcher, sponsor, ethics committee, they all should endeavor to minimize the risk to the participants as far as possible, so that there will be a potential benefit which will be tilting in favor of the potential benefits. Now, ethics committee is responsible to assess any kind of risk that may crop up when the study is ongoing. And again, they can always question or they can suggest in between also. This is the table which tells you about the classification of risk. Ma'am was already explaining, so I'll not go into detail. Just to quickly tell you, there are 4 types of risk as classified: less than minimal, minimal, minor increase over minimal, or which is also called as low risk, and more than minimal or high risk. Now, less than minimal will be where there is probability of harm or discomfort is not expected or nil. However, minimal risk would be something which is part of something like a routine activity, and it could also have, to give you an example, studies which include even some questionnaire and surveys or some of the observational studies. Minor increase would be something more than that, and of course high risk is more of interventional and studies which will be much more invasive. Placebo. Now this is one of the questions which comes up. Can we use placebo? So placebo can be only used when there is no established effective therapy, or if by withholding an established effective therapy, it would not expose the participants to any kind of serious harm, but only a temporary discomfort or delay in the relief of symptoms, or if the disease is self-limited, or if at all there is the use of an established effective therapy as a comparator would not yield any scientifically reliable results. The use of placebo would not add any additional risk or kind of serious adverse event, then we can probably use placebo. Otherwise, placebos are generally not recommended, not to be used. However, there are certain precautions to be taken. So these are some of the sets of precautions we can think of. I'll move on in the interest of time. there's another thing about surgical intervention, and many times surgical departments, they want to do some kind of interventions or trials. So please remember, ICMR guidelines suggest these. If there is an established surgical intervention which you plan to study as a researcher, there should be references provided for the procedure and what are the most likely complications. That is one. Again, when we describe this as a researcher, it has to be that each complication, what is the frequency that should be mentioned. And if at all there is a modification of already existing established surgical intervention is to be tested in a trial or in a study, the protocol and the informed consent document must specify why this modification is necessary, what are the expected complications, if any, and it's good to plan a comparative study where the conventional method is compared against the test intervention which is being planned. Now, if at all entirely new surgical intervention is being tested, the ethics committee is free and they may ask you for some animal data or modeling data, which probably will establish some kind of efficacy and the safety of that particular technique, or maybe some case reports which have been published earlier, or the case series which might describe about these benefits and the risks. So that would at least establish some and give some idea about the surgical intervention which is being planned. During the conduct of surgical intervention, all adverse events must be reported to the ethics committee, and if at all there is a sponsor, that also should be reported to. And provision of free treatment, compensation for any study related injury must be ensured for the trial participant. That is a must, which has to be done. Sham surgery. Now, what is that? So sham surgery basically refers to where we are not really operating, but there are times where, or it's not a real surgery, but a sham surgery. So sometimes that is there. Now, again, that is not usually to be resorted to. However, there are conditions where sham surgery may be resorted to, and these are also laid down. So there has to be a clear description for the justification why we need to have this. There should not be any serious harm if the sham surgery is being taken up, and the participant must get access to appropriate relevant intervention at the end of the trial, whenever that is. So that has to be, and in case there is a condition which deteriorates, obviously in between as well. Privacy and confidentiality, I've touched on this. This is the right of, the privacy is right of an individual to control or influence the information, whether they want to share or not, with whom they want to share it. Confidentiality, I've already talked about that. It's the obligation on the part of the research team. Now, once we have done the research, it's the benefits and the burden of research should also be equitably distributed. So it's not that, only when we subject them to the participation, but also the benefits have to be distributed. And as I've said already, it should not lead to any kind of inequalities, whether it's social, racial, or ethnic. And once we have done the research, we should already have it in the protocol. It's a good idea to have what are the plans for sharing the benefit once we are done with the research. So all types of research should have that. What about payment? Can we pay? So payment, yes, ICMR guidelines suggest that payments may be done, and they may be like the participants may be reimbursed for certain things, like if they are inconvenienced, they are traveling, they might have some extra incidental expenses, so they could be reimbursed for that. But one thing is sure, whatever it may be, if we are including them as participants, they should not be made to pay for any kind of investigations or whatever is beyond the routine clinical care. So that has to be the responsibility of the trial sponsors, or it has to be the researcher or investigator team or the institution. And EC's, again, responsibility and the job is to review and approve the payments, whether it's in cash or kinds, because both can be, or it could be a mixture. So whether it's a free service or some kind of a compensation or rather reimbursement being given, so all that has to be evaluated, and they have to see to it that it does not become an inducement. So what is the distinction? So a reasonable amount is all right, and that is compensation. However, if it becomes unreasonable, that becomes an inducement. These are the ways ethics committee communicates decision. After the meeting, they would communicate either as approved with or without suggestions or comments, or sometimes there will be a revision. Revision could be with minor modification or it could be major modification. And ma'am was showing you how the protocol, the numbers should change after that. And please note the fourth one, not approved. So they don't say rejected, they say not approved. And that means in the present form, obviously it's not approved. And please remember, this is always communicated in writing. Usually it will be coming from the secretary of the ethics committee. Some places I've also seen the chairperson writing, but it has to be communicated in writing. What about those institutions which are nascent, which are just coming up, which are probably just starting off, and so they don't have ethics committee? It's good to establish. If not, till that time there is a provision to use another ethics committee in the vicinity. There should be a MOU entered into, and there should be a no objection certificate which should be given by the user institution, so that the ethics committee of the institution where they are doing an MOU with, they can be overseeing all the researches which are happening, and they could also monitor, including site visits and other things. So that is also a provision which is there. Little bit on responsible conduct of research. I'll just touch on two aspects. That is conflict of interest. Again, I feel that conflict of interest is one of the most misunderstood thing. And to be honest with you, till some time back, I did not really understand this well. Not that I understand fully now, but I'm definitely better aware. So this refers to a set of conditions where, if now to give an example, if I have a primary interest and I also have a secondary interest. Now my secondary interest could be anything. It need not necessarily be financial. It could be non-financial. It could be I have an ambition that I want to climb up the ladder of my, say, association, my specialty association, and I want to please somebody. And by doing something, if I can probably achieve that target, so that becomes a non-financial, maybe a personal. It could be academic, it could be political, it could be even in the system itself. So anything I want to please, say maybe my director, my head of department or whoever. So all that becomes, and if that takes precedence over my primary duty or primary interest, which is the participants' welfare and the validity of research, that becomes a conflict of interest. So it's not wrong to have conflict of interest, or sometimes wearing multiple hats that we do, because I may be an investigator, I may be a treating physician, I may be an academic, and I'm wearing multiple hats. So I have multiple hats, and that might lead me to have conflict of interest. I might also be an ethics committee member, so I may have a conflict of interest, and that's why when a proposal where I'm a part is being discussed, I need to step out. So what is required is we must disclose conflict of interest, and that is something which is important. We have to learn to do that. And every study which is coming to the ethics committee, ideally they should evaluate it in the light of the disclosed interest or conflict of interest which has been there, and that should also be looked at. The next thing is about CTRI. So CTRI is something which is very important, and I think that still there is not much awareness about it, though it's increasing. So that's why I thought I should touch on this. So Clinical Trials Registry of India, or CTRI in short, it's a free and online public record system, and it is suggested that all the trials, including educational intervention trials, should be registered there. Any other research can also be registered. And it is mandatory to actually register the clinical trials from 15 June 2009. However, from 2018 April onwards, anything which is registered on CTRI has to be prospective. That means before the first participant is enrolled. Now, one thing you need to remember is you need to have the protocol, you need to have the ethics committee approval, and that's where like the uploading of the documents on CTRI can be started. So once that is done, there are multiple benefits. One, it becomes a documentation, it's recorded there, it gets linked. It also can in future be acting as a prevention of dispute, or in helping in dispute resolution. Now what can be registered? All research which involves human participants, including any intervention, drug, surgical procedure, biomedical, educational, behavioral research, anything, including Ayush. That means allied systems, Ayurvedic, Unani, homeopathy, Siddha, any system. And even observational studies can be registered, because many times I get this query. It improves transparency. And if at all it's a clinical trial, it's definitely a must. Many of the journals now will not take a paper until it is registered with CTRI. So you will find it difficult to even upload it. This has happened with me a couple of years back with one of my first PhD students. We could not upload the manuscript in the journal because in Medno group, because that journal wanted a CTRI number. And that's going to happen soon with many. Some of the conferences also look at this. Even the postgraduate dissertations can be uploaded. As I've already said, any kind of clinical studies, interventional, observational, BAB, post-marketing, everything can be actually uploaded here. So sometimes you might get a thing that, you know, I have a multi-centric trial which is being done elsewhere in some other country. What do I do? So yes, they may have registered it. If you have the primary registry number or a partner registry number, that can be added in the secondary ID of the CTRI, because please remember, this is a WHO linked registry. In India, it is facilitated by ICMR, so it will automatically get linked. So that is something which is required. So any trial which is conducted in India must be registered with CTRI. And that will actually also help, especially for people who do some kind of systematic reviews and meta-analysis. Many times they look at these databases also. So that's also something good. And for people who do research, it's a good idea to even look up at CTRI, because you will know who are the other people who might be doing something similar, some similar kind of research. That also is a good database to do that. So with that, I would stop here. And if at all there are questions, or as the organizers say, whatever. So I'll stop here. I tried to give you an overview of many things in this short capsule. I know that some places I have rushed a bit, but that's the best I could think of. Thank you so much for this opportunity.
Thank you, Dr. Animesh, for that explicit lecture on ICMR Guidelines 2017, General Ethical Issues. There are a few queries, however, we'll keep it to the end because we have one more session before we close. I now call upon Nandini ma'am to speak on ethical issues in biological material transfer and biobanking databases. Dr. Nandini ma'am. Maybe as Dr. Nandini comes, I can...
Yeah, no, wait. Dr. Nandini will come online now.
Okay.
I'm there. I'm trying to actually upload.
Yes, ma'am.
Can you see my slide?
Yes, ma'am. It is not in slideshow, but we can see it. Yes, now it is fine.
So actually, I'll be talking on biobanking data sets as given in ICMR guidelines, as well as some extra points there. And also, since I was also told to speak on biological material transfer, my last slide would be on that. So please, if I'm overshooting the time, please let me know 5 minutes ahead. Now, when we talk about the biobanks, it was supposed to be very important, even in very early times. And you have this Time magazine actually projecting that, you know, so many points, and that biobanks stood at strong ground. Now, in ICMR ethical guidelines, we have these 8 points talking about biobanking, storage of specimens, and then ethical issues related to donors, related to research, biological material and data in forensic departments, laboratories, governance, special issues related to data sets, and then contingency plan. I will not go according to this in that order, but these points would be covered in my presentation. So when we say biobanking, it means repository or biobank is an organized collection of resources that can be accessed to retrieve human biological material and data. Now, these could be leftover samples, biopsy materials, surgical autopsies, specimens, tissues, embryos, fetuses, cell lines, cord blood, gametes, and also the waste. This is very important because I would actually illustrate one interesting case study on that. And because they are termed waste because they are abandoned, supposed to be abandoned organs and tissues once the primary objective is over, that you have diagnosed, and after that they keep it for say 6 months or whatever period the policy that they have. After that they send it for incineration. Now there are also non-human materials which are stored, that is animal, microbes, parasite, etc. So when we talk about repository, it starts with the collection of biospecimens and how you store it. So this becomes the governance mainly. And then the retrieval and disbursement to the researcher, whom to give, how to give, why to give. So when you talk about data set, it is actually an organized collection of data and information maintained in physical and or electronic or digital form. That what you see here are the huge facilities, server facilities, which are holding a huge data, what we call big data actually. So what are the repositories that you have? I mean, this is not a comprehensive list, but you have this disease genetic registries, health surveys, population-based, disease surveillance, census data, personal health records in healthcare institutions, and forensic. In fact, there was an incident, I mean, an interesting development with regard to all the HIV data that our country has, how to keep it confidential, how to go about it. That was a big discussion. And the IT department is also the information, the what you call Ministry of Electronics and IT, Information Technology. They also have actually submitted a bill on the same element. The privacy and confidentiality is the biggest stumbling block when we talk about repositories. Then the samples that we actually have, there are 3 main differences. Like, they can be identified. If they are identifiable, then there's a direct link to the participant's identity. When you code it, then it can be reversible or irreversible. When it is reversible, because and you have anonymized it. So when you have anonymized it, you will not be in a position to take the results of the project that you have done. If it is beneficial for the patients, you will not be able to inform the patient. So what do? So in recent years, this was divided into, anonymized sample was termed as reversible anonymized or irreversibly anonymized. When you have this irreversibly anonymized data, then you can't link it back to the participant's identity. When you can't link it back, then it becomes anonymous. Now, with regard to privacy, let us see what is the position. When you have identifiers, it is lowest, privacy is lowest, as you can understand. Then it increases as becomes coded, then anonymization, and then anonymous. So here you have the highest degree of privacy. Now, what are the ethical issues involved? Mostly it concerns informed consent, IEC approval, legal positions, intellectual property rights, and ownership. Now, when you talk about informed consent, ICMR gives several options. Blanket or broad consent. Many a times I've seen in the proposals, when you talk about preserving the samples, the common sentence that goes is, this will be preserved for future scientific purposes. That is a blanket statement that we generally see. Tiered consent. At each step, you take a fresh consent, a specific consent that you are going to do this study and you are going to use it only for that. So that is specific consent. And then delayed consent. So sometimes you may take it later. You would have got when you got the biospecimen, you did not even think about doing something with that. But now you have an idea, you want to use it, then also you can go back and get the consent. Dynamic is, of course, it is related to the electronic system, technology based, it is actually, and it accommodates both the participant as well as the researcher. Withdrawal of consent can be there, or destruction of sample. And this is what the bill that I was talking about, Ministry of Electronics and Information Technology, it has this, this phrase, this possibility there, that anytime the donor can withdraw consent and also ask for destruction of a sample if necessary. Now, you don't want to destroy the sample, you need it. It's very necessary because you may actually come across some new technique and then you may like to use it to see whether you come across some new discovery. So in that case, you will write in the informed consent document that in case you are withdrawing, we will continue to have your sample and data. And if the patient doesn't like it, the patient doesn't get enrolled. And if the person says, okay, fine, let me in, then the patient cannot later say that you didn't destroy my my biological material or the data related to me. They cannot argue like that. So this is actually a legal position. And sometimes there might be a waiver of consent, especially when you use anonymized, de-identified samples or data. Then there are actually reconsent. Secondary or extended use of stored samples and data sets. So every time you may actually have to go to them to ask for permission. So that's why you have this phrase, it may be used for future scientific purposes. Sometimes, there may be situations where it is impossible to get the consent. Then it may be actually done only after the EC approves it. Now, when you have pediatric donors, the pediatric section actually gives you, the child participants give you assent. And if they are less than 7 years of age, the parents or the legally authorized representative, legally acceptable representative, give the approval or consent. So after 7 to 12, it is oral assent, but you have to document that. From 12 to 18, it is written assent. Now, having gone beyond 18, your age is now 18 plus. Then in that case, if you are still in a study, long-term studies, long-term follow-up, if that is there, then you have to give a fresh consent. So there are 2 things that one has to think about whenever a blood sample is or biological material is collected for testing for research purposes. So you may have the phrase that it will be used for any biomedical research or for that specific disease or other specified diseases. For example, it's a sample from rheumatoid arthritis. So it's a specific disease. Now here you may say that Also those people having rheumatoid arthritis who have diabetes and hypertension. We test it in that also. So that intention should be very clearly stated in the informed consent document. Now, you may also give them the option of refusing. So you may say, the person may say that if it is to be used beyond scope of this particular proposal, then you better get my reconsent. Or they may say that no future research with my samples. So in that case, you cannot store that sample for future research. And you have to be very, very conscious and honest about that. And then they may also say that don't contact us later. Why? Because you may want to inform them about the results of their investigation. So this is the other option that you give. I wish to be informed and not be informed about the results of my investigation. So these two factors are very, very important when you are dealing with biological material. So this is one story. And from this, you will actually get an idea about the ownership and custodianship. So this was for a period, this gentleman, he was a Dutch pathologist. He removed tissues, including organs from 850 children under the pretext of finding solution to cot death. There used to be something called cot death among children those days. So once declared dead, the organs and tissues used to be removed by this gentleman. Now, this was in Bristol Royal Infirmary. There was heart surgery done on children. So at that time, no parental consent or information was given for removal of tissue or organ. You are actually, admitted there for heart surgery, but you are also taking other organs or tissues. So in 1999, there was a public inquiry, which was initiated by Helen Rickert, and they found that there were 2,000 containers with body parts, and 1,500 were stillborn, inadequately preserved feti, kept in the basement of the hospital. What was he trying to do? So as a result of this, there was a big public hue and cry. And as a result of that, the Human Tissue Act came by in 2004, and a Human Tissue Authority created, set up for that. So this is just a quote from one of the mothers, affected mothers. So it didn't seem right. A heart belonging to my child could be part of a collection like butterflies or insects, something to be visited and looked at. So no consent was asked, and some of the parents had to actually undergo the burial scene number of times, because once they will give you the heart, first they will give you the body, then the heart or the kidney or whatever. So there were different codes during that time, very pinching actually. So the ethical issues related to research is about the ownership. Who owns these samples? And then you want to transfer. So this also involves a number of things. And you want to use for future scientific purposes, then that means you are going to use it second time, third time, fourth time, but it's all called secondary use. And then you also need to, actually it's your obligation to return the results. But when it comes to genetic studies and all that, people may not want to know the result. Especially when you are going to, you are suspected to be having a genetic disorder which may manifest later in life. People may not want to know that, why should I know it now itself and be under tension whether I'll get it or not? And the famous instance being the diagnosis of BRCA1 and BRCA2 genes, which actually indicates that you might develop breast cancer. So this was a big question in Ashkenazi Jews, where they were very susceptible for breast cancer. So there was a big dilemma for them that do I get tested or not tested? Then we also talk about benefit sharing and the role of ethics committee in this whole affair. So then you have this earlier times, people used to take the material, run away to their country, and then do some research and publish it. Not even give some credit to the original donors about that. This is nothing but biopiracy, which used to be used at that time. So you can use the biological specimen from the transplant, and then you can test for genetic susceptibility and other products. Drug development is very much a part of that. And in India, you have so many castes, so many communities, and so many endogamous groups, and each one will give you a rich genetic data. And you use it for various studies, anthropology, pharmacogenetics, and this is the one which actually has a commercial angle. Disease susceptibility, this leads to stigmatization. And then stem cells, again, a commercial angle is there, and then of course your forensic purpose. So it is either to publish paper or to earn money that you might be targeting your research to for testing biological samples. And in biodiversity rich country like India, this can be a great issue. The diagnostic keeps bringing in a lot of commercial angle. So this is the story of John Moore. What happened? He had a splenic cancer called hairy cell leukemia. So in 1976, he went to Dr. Gold from UCLA, who actually removed the spleen, but he kept the cells in his lab after more surgery. So normally what we do is, for surgery, you take an informed consent, and you are only thinking of, you are told that your liver, your spleen, whatever will be removed. And then that is sent for doing histopathology to get the diagnosis. That's it. The patient doesn't bother about it afterwards. What's happening to the specimen? So this gentleman also took informed consent from Moore for the operation, and then removed the spleen, but he used it for various testing in his lab. And then he made Moore come several times to his clinic. He had to travel from Seattle to California just for that. And then in 1983, he applied for patent. So he, as well as the institution, becomes assignees for that. He and his colleague, both of them and the institution became assignees for that particular patent. So it's on from 76, 7 years later, Moore realized that the doctor had patented the cells. I'm cutting the story short, and he found that he had commercialized it. Now Moore sued Dr. Gold in 1984, but he lost it on legal ownership issue. 1988, California Court of Appeal reversed the decision, said Moore was actually cheated. But then what happened? Supreme Court of, sorry, this is not California, this is US, overruled it again. They said that, whatever tissue is taken from your body, you don't have any property rights on that. The point is that Dr. Gold made a cell line called Mo, having these two words there. He used that cell line, and then he sold it to another two concerns and got a lot of money out of that. So the court said that he had no property rights on the cell line Mo. And Moore did not provide, but also acknowledged that Moore was not provided with acceptable informed consent, because he was not asked. He became suspicious when Gold asked him to sign an informed consent where he was told that he will not have any rights on his spleen, the tissue that was removed. So he became suspicious, and that's how he found out through his lawyer that this was what was happening. So US does not have, protection in terms of tissues which are removed from the body. And they say that it has a social value because you can develop drug development can happen on that, and so many other things, you know, arguments went on like that.
YouTube is almost over than
In short, the person could not claim. And moreover, although it acknowledged that Moore was not given the document where he had accepted to part with that as with the purpose that Dr. Gold would use it for research. So there was no acceptable informed consent. Now this is important for a later episode that I would be relating to you. That means once biological material did not have any rights on that biological material which is removed from the body, in short. Now, this is another instance where he was he tested tens and thousands of tissue samples and developed the PSA test for prostate cancer. Now he got shifted to Washington University. From Washington University to Northwestern University in Chicago. So he wanted to take the samples with him. But the Washington University refused. And then they went to court. And then the patients were called. Now patients wanted transfer to Chicago because they said that they had actually gifted that biological material to this gentleman. So he can take it. But then the court asked, did you sign to that statement in the informed consent document about your rights? Now here is what was said, that no property rights are there. So it becomes like a gift here. So that was the argument that this gentleman, a patient, said that it was gifted to Catalona. But the court went against it and said that samples which were considered a gift to the university cannot be transferred. So therefore, we come across this question about ownership. So ICMR guidelines is very, very clearly stating that the donor is always the owner. And the researcher or institution are the custodians. So the right always belongs to the donor. What was given, and then what does the ethics committee do for the secondary use? So it looks at the original consent that was given in the earlier research. Now, if the patient has refused or the participant has refused that her or his samples are used for future research, then you just cannot take that a sample for your secondary use. So in that case, the ethics committee may say that somebody should check whether the informed consent document states this or not. It's a big job, but maybe ethics committee may actually give an approval in that sense. Then validity of objectives of the new research, what are they? They would like to know. And then are there provisions for anonymity? I already told you, reversible and non-reversible anonymization. And then permission of legally authorized or acceptable representative for post-mortem use. Whenever you want to collect the material in the post-mortem stage, you will have to have the permissions, necessary permissions. And then consent form should mention the retention and future use. I already talked to you about this. And also waiver of consent in some instances. Now, it is a decision on case-to-case basis. Anonymization is one, and then waiver of consent. If the donor is not traceable or the sample or data is anonymized, then you don't require consent, or it is impractical to conduct the research. Then also you can actually go in for waiver. And in certain instances, reconsent if the participant has signed it that way, that if you have to do future research, please take my consent again. The return of research results, as I told you, this is the second part, which was very important. So you have individual data, you have aggregate data. Now, when you have individual data, you have to take care that this information doesn't lead to harm. And this is especially true when it comes to stigmatizing diseases like genetical disorder or HIV and similar diseases, where there's a lot of stigma attached. And now you may even talk about COVID. So the person before collection of the sample has to be counseled. And after you get the results also, the person has to be counseled. So there has to be a pre and post counseling. And options should be given, as I told you earlier. And if it is from a community that you have drawn the material, and that community is a very vulnerable community. See, when we say community, it's a group of people. So you can have heart patients as a community. You can have a village as a community. You can have a community within a community as a community. So you have to see what is the status, how vulnerable are they? And in that case, and what is your research? Based on that, because the research also can be very sensitive. So you provide only the aggregate data. And if there is any benefit sharing involved, you have to involve them also in the discussion. So what is the benefit sharing? That you have to have a necessary clause for clarity about benefit sharing. It can be to the donors, their families or communities for products, tests or discoveries resulting from the research. And if it is a community-based studies, you have to tell them what the benefits they would get in case there's a commercial end to it. And one has to be always kind and considerate about this. And ethics committee should always consider these possibilities. Earlier times, it used to be all on paper. Nobody was bothered about it. But now, in the NDCT rules, which you are going to actually listen to, you will see post-trial access has become a law now. So for all regulatory trials, at least, that has come to stay. Now, what about forensic departments? You get so many bodies. You say that in pathology department, you don't have any bodies, but in forensic departments, you have plenty of bodies. So many researchers actually go to the forensic department to get their tissues or whatever they want to test for their thesis. So that's why it's a good resource. Now, here, these materials are also used for data sharing for tracing missing persons. So that also may actually require research. So forensic department itself may want some research to be done. And if no written permission is there from the deceased persons, the family can be approached. But then, if the sample or data is anonymized, or if the deceased has no claimants, then there is no consent involved. And the forensic official is authorized to give permission for the use of material, and that person is responsible for the use of unclaimed cadavers. Sorry. So if claimants are present, you have to actually take their permission, and you have to be very careful how you are taking the tissue, especially if it is from the external part of the body where everybody can see that. It's a very sensitive and delicate position. So how you will deal with it, actually it is the forensic official who will actually talk about it and see that there's no cultural violation while giving the tissue to researchers for that, for their purpose. The informed consent document should state what tissue or organ will be retained, who will be the custodian, duration of storage of sample, type of research, and how remains will be disposed. Genetic research or revelation of any other stigmatizing factors like HIV in the deceased may have implication for the family members. So you have to actually see all the ethical requirements that may be required under these circumstances. And then EC should approve the type of consent, whether it is broad, tiered, option to opt out, or specific, and from whom it would be taken, or whether anonymization should be resorted to. All these are actually the decisions to be taken by EC. Now, as I told you earlier, there's a collection part, there's a maintenance part, and there's an outsourcing part. So for all this, you need to have a governance system. And that is provided by the Technical Authorization Committee. If it's a big biobank, big data collection, you need to have this committee separately and a separate ethics committee. So what will the Technical Authorization Committee do? It has to be separate from EC, and it should work in tandem with EC. And it should actually take care of all the regulatory aspects that may be required for that, like material transfer agreement, data transfer agreement, etc. And have well-structured SOPs, clear guidelines, because you will have to decide from where you will collect the samples and where, to whom will you give it. And the interim period, you need to keep everything in order so that the samples are not destroyed by fungal contamination and things like that. That's very, very important. And then you have to have, the committee will comprise of clinicians, geneticists, lawyers, basic scientists, sociologists, epidemiologists, statisticians, and ethicists. So the issues related to data set also are almost the same. And then it has to be actually followed with due diligence. EC review of tools of data mining and other data science. They say that, people say that in the PowerPoint, suppose I show a figure, even if I put I try to camouflage the face and all that, there are people who can actually trace where this person is coming from. It's too difficult for me to understand, but that is possible. So the purpose for which the data would be mined has to be stated. Who will have access? That is also important, because a lot of privacy and confidentiality issues are involved. Whether this information will be useful for any particular groups, what about data privacy, accuracy and security, possibility of any legal liability when data is outsourced or sold. Auditing could be done to detect misuse. Then we have the big data. Ensuring physical safety and security of the involved devices and computer servers are very, very important. If you don't have that, don't store big data. So you have to have password protection. And then the members of the research team, they will be assigned, each one will be assigned a particular role. And depending on that role, they can have access. Data encryption is another point, and benefit sharing, as I told you earlier. So what they say is, since India does not have a Data Protection Act as yet, there is actually a Personal Data Protection Bill 2019 submitted to Lok Sabha by the Ministry of Electronics and IT. So let's wait what they state there. And then the IT Act sections can be applied for the data security. For sustainability, you have created a data bank. Earlier days, you could get advertisements saying that you have to pay 1 lakh or 1.5 lakhs and all that for preserving your baby's cord blood and things like that. So the maintenance also involves a lot of money, which they were trying to take from the people who wanted the material to be stored. Now there's no guarantee whether it will be, contaminated and things like that. Who has that? Who can give that guarantee? That is part and parcel of the governance. Now today, a blood bank owner or the management feels that enough is enough of this biological biobank. So let us do some other business. They cannot go like that, because it has been entrusted to you with the full faith and trust that you will preserve it for, say, that number of years, 16 years, 18 years, whatever number of years you have signed for. So you have to hand it over to an appropriate party before you try to change your profession. So these, I end with my two case studies, which everybody should know, because this is very much, I told you, in states, they never considered biological material removed from the body as belonging to the person from whom it was removed. Like that person doesn't have property to that, rights to that property. They treated it as property, which had to be used for social cause, drug development, and things like that. So they didn't bother that the person is deprived of the benefit that otherwise they could have had. So this actually is a Havasupai tribe. Initially, it was a group from Pima tribe of Mexico. So they settled in the Arizona valleys, and they suffered from diabetes. So 200 samples from this group, from 650 members, were taken to the Arizona State University by two anthropologists who stayed with them for a number of years. So they had the trust. And then this lady, she is the tribal council member. She joined the Arizona State University, and she was told by one person who was interested, one faculty was interested in their tribe, told her that there's going to be a presentation now by a PhD student. Would you like to hear that? She said, why not? She went there, and then she found to her shock that this PhD student, so this blood was given for research on diabetes. So she was shocked that this PhD student was presenting something else, genetic susceptibility, schizophrenia, and all those things. She got up and she said, who gave you the permission to do this? Did you take informed consent? And she's Carlotta Tilosi. Then they went to court. And this is Carlotta being offered a big carpet by the organizers of a conference where she was in the panel to give her experience about the whole affair. And then 2010, they won the suit, and a small amount was given to them as compensation. And remaining samples, you know, tribals in US especially, tribals do not want to part with their the biological material, because they believe that when a person is dead, all the material with that person goes to whichever place, heaven or whatever. So here they got the samples which were left over, they got them back, and they buried with the person to whom it was supposed to have belonged. And they called it as an act of healing. And with the money that they got, they actually set up a clinic and a school. So that is the benefit sharing that they got. Okay. Now, next one is, most of you would have actually read about Henrietta Lacks's story, The Immortal Life of Henrietta Lacks by Rebecca Skloot. She became quite famous because of this book. And this is written on this lady who died in 1951. She had cervical cancer. And then at that time, one researcher this was in Johns Hopkins, and one researcher in Johns Hopkins was trying for a number of years to develop a cell line which was tenacious. And he found that these cells were that. And those cells then went all over the world for various studies. One of them I can quote is the Salk vaccine for polio. And unfortunately, the family got nothing in return. There was no informed consent taken from her in the first place. And remember, informed consent, Nuremberg Code actually brought the concept of informed consent, and that came out in 1947. And this is just few years after that. So the Americans, I don't know whether they knew, just like most of us in the country don't know that there's ICMR guidelines available. If some know, they have never read it. So similarly, maybe the American doctors also may have ignored it, and even otherwise, Black Americans were considered inferior at that time, even now for that matter. So 25 years later, again, cutting the story short, the samples were taken from the family. There's a story behind that anyway, but they were also not told about the results. Then there was a European research which actually published a paper on genome of Henrietta Lacks cell, HeLa cell. It was called HeLa cell. Just as John Moore's cell line became cell line Moore, this cell line became HeLa. HeLa means he from Henrietta, La from Lacks, HeLa cell. So then this created a lot of furore, and then Rebecca Skloot got a number of emails and all because her book had become quite famous by then. And then she wrote to the NIH director to take a stand, and then NIH took a stand on that. And what was that stand? It was to include 2 members of the family for any research which involves HeLa cell. And this is the great grandniece of Henrietta Lacks, and this one is the grandson. And this is, she is a lawyer, she is a granddaughter, seen here. So they are all educated, whereas her earlier family was not educated at all. So it came out that patenting genetic tests for cancer based on HeLa cell mutations would be allowed, but then US Supreme Court said that unmodified genes could not be patented. Suppose you have taken that gene, you have taken that cell and you have modified some genes and all that, and then only that can be patented. So the HeLa agreement with NIH was that a committee that includes family members will handle requests and papers that use the data, will recognize Henrietta Lacks and her kin. So initially, this gentleman, when they were invited for dinner to NIH director's house, he was telling that it was a big thing for them to have dinner with him. And then when they were sitting in the meetings, he was telling, they talk about SNPs, expression of this and that, and all that has no meaning for us. But we are very worried about our the preservation of our family privacy. So what happened here in the previous one that I showed you was this European research. So what the family, by this time the family was quite educated to understand the implications. They said that our privacy is invaded. So that has to be prevented. So this is Henrietta Lacks' husband. Henrietta Lacks actually was a dancer also. So one researcher said that she was dancing, her cells were dancing all over the world, but the family got nothing in return. So benefit sharing, nil. So the Henrietta Lacks allowed medicine, another biothesis, he made a comment. And now this gentleman is the one who gave the name HeLa. So Henrietta Lacks allowed medicine to make great strides in the struggle against illness and premature death. 6 decades later, our descendants have allowed ethics to make a great stride as well. So now about biological material transfer. This is my last slide. There has to be MOU between the partners as equals. Nobody is higher and the one being higher and the other being lower. No, that is not done. Earlier times, it was more of a reality that one dictated the other. But today, with proper guidelines in order, you can fight actually. But even today, I find that in many multi-centric countries with a foreign collaborator, people are, very anxious that the ethics committee should approve it. It should not ask any questions, because it's a prestige to have collaboration with such and such person. Of course, they are dreaming of papers with that person. All that will be denied if ethics committee behaves in this manner. But it is actually to protect you. So material transfer agreement, what are the wordings in that, whether it protects you or not? And also whether it protects your people, your participants, they should not be exploited for somebody's benefit. And when it comes to international collaboration, so when I say about partners, it can be national or international. So international collaboration, you always have to have Health Ministry Screening Committee approval, which is mandate. And protection of Indian research, what they see is protection of Indian researchers' interest, and also whether the information that goes out is sensitive for the country. And also sees that there's enough of capacity building there, because you have exchange of scientists also in the bargain. So with that, I end my talk, and thanks for your patient hearing. Concluding this, you know the difference between donor and owner. It's very clear cut in our country. And donor is always the owner. Custodian is the researcher and the institution. What are the different types of consent that you can take? Secondary use, its implications, return of results, its implications, benefit sharing wherever possible. And EC has an important role to play. And then how you have the governance, etc., of biobanking, biorepository, data banks, repositories, and of course the material transfer from one place to another. So, any questions?
Indrani ma'am, please unmute yourself, ma'am.
Yeah. Hello.
There's a bit of echo at your end, ma'am.
Must be two apps open.
No, it's not heard by them.
It's good now, ma'am. It's good.
It's okay now? Now?
It's fine.
Okay. So thank you, Dr. Nandini, for that extremely educative talk on ethical issues pertaining to biological material transfer, data set management, as well as biobanking. Yes, there are a number of questions, and you very rightly said, in understanding many of these topics, in India we have been a bit ignorant, and when we are asked to sign the material agreement form and send it to the ICMR or to the DBT, there has always been a kind of apprehension in the mind of the researchers when they sign, because the thoughts are that we will get a kind of reply that will not be very encouraging to the collaborative research that goes on. But at our end, the education is very important, and I think the organizations like Indian Council of Medical Research, the Department of Biotechnology, Department of Science and Technology have also to play a proactive role in trying to make it easy for the researcher and advising them so that the interest of the researcher in this country is protected. Now, there are quite a number of questions. They have come through different chat boxes, and that is why I would like to start with Dr. Lakshmi Radhakrishnan, who has asked, what is the need for ethical clearance for research that are based on survey methods? There are 4 questions, so I will ask one after another. Can I have your answer, please?
Can I hear that again?
What is the need for ethical clearance for research that are based on survey methods? Survey methods.
No, survey method, it depends, you know. Survey methods, if you are going to do it for, finding out, for evaluating a particular strategy or something like that, it doesn't have to, it comes under exemption because it's a service, actually. But if you want to extrapolate that in some other geographical locations, you're using the same survey questionnaire, then it is research. Because that's a new area where you have not applied your strategy. So there was no service there, but you want to actually find out how it will be with these people. So that is research. That has to come to ethics committee.
Okay. Thank you. How may we utilize data that are obtained through opinion poll at international forum that have later been thought to be consolidated for a study?
That was in public domain. If it is in public domain, it comes under exemption.
She has also asked, how do we go about gaining ethical clearance for action plan research studies when they are messy and largely subjective by nature?
So the first part of the sentence, what is that?
How do we go about getting ethical clearance for action plan research studies?
Anyway, you have to submit your protocol to the ethics committee. That is how you have to go about it.
But she has answered by saying when they are messy and largely subjective.
No, doesn't matter. Let it be messy or subjective. The ethics committee will opine on that. And with that, the investigator, actually ethics committee is also a friend, you know. Ethics committee is seen as an enemy, generally, you know. They are sitting there just to object. But they are also your friends, you know, they teach you also. So you take, you know, that messiness can be reduced. It can become more standardized with their advice. Either they will say, go to hell, not approved, rejected. Okay, if you have not been able to answer the questions, but if you have answered the questions and they find that you are a little confused, then they will suggest that why don't you do this, why don't you do that, why don't you consult such and such person, or you can come to me, I will advise you if the subject expert is there in the committee. So that way, you know, they also help you solve problems.
Yes, we are very lucky in having Dr. Chakrapani, who describes, who I can describe the way you have now presented, a friend for all researchers and help solve many issues without stalling any program, any research project. Then she also has one last question. I know she's a PhD candidate, a professor, but she's interested to have these points clarified. Can retrospective ethical clearance be obtained for research studies, especially if they are studies with lesser ethical concerns like population surveys or opinion polls?
Yeah, retrospective studies can be done.
Okay. Now there's
retrospective studies can be done provided there is an undertaking given that the information that is there will be de-identified by a third person. That has to be given. If it is faculty has to give the undertaking. If it is a student, then the guide has to give an undertaking that this will be done under my supervision, and I will guarantee that this will be de-identified by a third person.
Thank you. Dr. Vandana Kumar from AIIMS wants to know the following. If an institution research takes a sample from a private hospital, but tissues would be anonymized, then does the private hospital need to do any additional documentation?
See, if the private hospital is just a supplier, then the private hospital has to give a letter of a letter of permission for taking the samples. But suppose you are taking it, see, you can't enter the premises without the institution's permission. That private hospital says that if you are going to take samples from me, this is the nodal person to whom you have to report. Then that nodal person may actually say that I would like to be a collaborator, not a supplier of samples. In that case, you have to have a letter of collaboration. And then further demand would be, I would like to be an author in your paper. So that actually has to be followed according to what ICJME says. What is the percentage of contribution? Is it only a supplying the material, or has that person been involved very closely in discussions around that?
Thank you. Dr. Rangil Raina from Government Medical College Almora is asking how to handle PI who is applying for ethical clearance for evaluating efficacy of 3 different herbal/Ayurvedic preparations in combination without sufficient data of safety for study in patients.
So first of all, the ethics committee would require whatever literature is there available for all these 3 herbals. Okay, whether there is any report of toxicity, which they have to actually highlight in their proposal. They cannot imagine, like they cannot pick up from here, there, everywhere, and then make a concoction like a fixed drug combinations. So they have to provide the literature, the authenticity of that. And suppose it's a proprietary drug, because herbals are actually classified as the ASU drugs described in the authoritative textbooks of ASU. ASU is Ayurveda Siddha Unani, which is actually enlisted in the Drugs and Cosmetics Act. But if you are going to mix up some ingredients from here and there, and that mention is there about usage for a number of years, centuries and all that. So then you will have to, initially ICMR had given a direction that you have to do a limited toxicity studies. But now the Drugs and Cosmetics Act actually talks about it in terms of manufacturing, the requirements. You have to do certain tests and things like that. For certain things, you don't require tests and things like that. So when you are actually making this, naturally you will have a tendency to commercialize it. So in that case, you have to consult a subject expert in that science. Suppose it is Ayurveda, Ayurvedic expert, Siddha, Siddha expert, and so on. Get their opinion, but be very, very careful who you choose. Because the person should be a learned person, not somebody who is already, who is an Ayurvedic expert, but doesn't know much. It's just like any science, we have good ones, we have bad ones. So the choice of expert is very important.
Thank you. Ms. Meenakshi Reddy from KMC Mangalore asks, asking for consent for the welfare of patients, especially during research, how far is it ethical?
Consenting for the welfare of, I didn't get that.
Asking for consent for the welfare of the patient, especially during research.
Actually, the thing is, you're taking consent for that only, for protection of the participant only. You are having all this drama about informed consent administration, which is supposed to take care of that. And many times the informed consent, I'm very sorry to say, the senior experts, senior researchers, I must say, they have only half page of the patient information sheet. They take it like a joke. The ethics committee questions that. They're so angry because the chairperson may be a younger person compared to them. So informed consent is supposed to be supportive about the welfare. You have to talk about risks, you have to talk about benefits, all that. The patient will have to know all the details. That will take care of their welfare automatically.
Maybe the person who has asked this question is looking at asking consent for the welfare of patient in the Indian context. For instance, if we are handling a patient who does not know they have a particular problem which may be extremely sensitive, some cancers, and you want to use it for research purpose, but you don't want to let the patient know that this is what is the report. So maybe that could be because in the Indian context, there would be few who would think everything should be told. There would be others who think, I do not want to know anything. I do not know whether that is the attitude.
I understand. Medical practice actually talks about truth telling. Okay, and truth telling is a big cultural problem in our country. Because many a times the children say that please don't tell my father that he is suffering from this or my mother suffering from this. So if you are not going to tell that, then you can't include that patient in the study. Patients are walking into the cancer facilities. Okay, and if the patient doesn't know that person is having cancer, then you can imagine what is the mental level. Okay, so better to avoid such patients.
Okay. So Dr. Vandana Raghunath from Narayana Dental College and Hospital asks, is ethical clearance for clinical studies using a herbal or Ayush related medicine for dental procedures, which has already been proven beneficial in medical procedures, considered under regulatory clinical trials or under academic or non-regulatory clinical trials?
Right now, it is non-regulatory. Non-regulatory includes academic as well as biomedical and health research.
Is ethical clearance a mandate for retrospective studies, systematic reviews, and meta-analysis studies?
What did you say? Ethical?
Is ethical clearance a mandate?
The ethical clearance is a mandate. That piece of paper that you get about their approval, exemptions, all that is required. The ethics committee may exempt it, but that paper is required, certifying that this is exempted. And the other two anyway go through the review committee meetings, and the minutes are there, but based on that, approval letters are received.
What's the maximum period for giving ethical clearance for academic, non-regulatory clinical trials, postgraduate dissertation, following which it needs to be renewed? Is it till completion of the study, which will be of 2 years maximum, or for 1 year and ask for renewal?
Actually speaking, the minimal risk type of proposals require only an annual report, progress report. Those which are active, and this doesn't actually, most of the postgraduate students don't opt for complicated studies. Okay, they have their timelines to follow. And the period, how long it takes to actually decide, that depends on how the proposal has been presented. If it is in a shabby way, naturally there'll be more delay, because the ethics committee will say, do this, do that, and all that, and they will take their own time to clarify and resubmit, but they will blame the ethics committee. This has happened, I have seen that as an ethics committee member also.
I think the concern here is, will it be given for the period of study, say 2 years, or is it given annually? I think that is the concern.
Yes, that's an important question. Sorry, thanks for reminding me that. It is given for the whole period. If it's a 2-year study, 3-year study, it is given for the whole period, but they are supposed to give the annual progress report. Only after receiving that, within the time frame, they will allow you to proceed for the next year. So every year you will have to renew the ethics committee approval. And this will go through, mostly it will go through expedited review. And the point is that if, say, 2-year period is getting over and your study is not over, this is for faculty mostly. And then what do? Then you have to write to the ethics committee saying, requesting an extension period. And that should also be submitted well in time, not after it has expired.
The same doctor wants to also know, what are the points to be considered with regard to giving ethical clearance in COVID-related times for academic clinical trials? Not for COVID-related work, but during COVID-related times for academic clinical trials. What are the points to be considered, she asks.
So this will be actually, if it is not COVID research, it will be a non-COVID research. So now that non-COVID research may be a new proposal. So it will be subjected to the same rigor. Only thing is, ethics committee, when it is, bombarded with so many COVID proposals, which they have to clear within 72 hours or latest by 1 week, they may not pay attention to the new proposal, because the new proposal will go through the normal cycle. Say you meet once monthly or once in 2 months. During that cycle, it will be reviewed and the approval will be given. Only thing is, it will decide whether it is necessary to actually go through this proposal or not. The investigator will say that, yes, it is necessary. Please give your opinion, approve it. We will keep it ready. When we are going ahead with that, we will inform you. I mean, the ethics committee will have to actually ask that when the first patient is enrolled, inform us. I think Sudha has raised her hand.
Yeah, but there are many more questions here. She will come to her question as well. Now, Meenakshi again says, how to obtain consent to avoid Hawthorne effect?
That's a big loaded question. Hawthorne effect, actually, you know, it is there, but it wears off after some time. So you come to the true picture.
Okay. Dr. Shiva asks, is clinical registry essential for item design validity and survey on health profession college students research project?
See, you heard Animesh saying that any type of research can be registered in CTRI. CTRI, actually CT means clinical trial. But our CTRI is not exclusive for CT. It can take any type of research. And it is better to actually register in a registry because as Animesh was saying that sometimes, you know, the journals will ask for the number and you don't have the number, then what do you do? And I have also known about some students who have had very good research, wanted to actually submit as a paper, but they could not do it because they asked for a number. High impact journals definitely ask for that.
A non-medical institution, Dr. Blossom, wants to know how to get human ethical committee sanction for a study if the institute in which the research is being conducted doesn't have it.
So there are two options. One is constitute your own ethics committee, but suppose it is not feasible to do that, then approach another institution which has an ethics committee, good running, well-oiled ethics committee, and then you have to have MOU with that, provided that ethics committee accepts to review. And because the ethics committee, which is going to, you know, this is called user agency and host institution. The ethics committee of the institution which accepts it becomes the host institution. That institution becomes the host institution. There has to be MOU between the two groups because approval is not enough. You need to monitor as well. So when the host institution wants to monitor, then they cannot say that, no, you have given us the approval. No, there's no need to come to our premises because for monitoring purposes, they want to see your records, everything. They want to come to your premises. That won't be possible if you have not gone through the MOU.
Then, is there Dr. Preeti from Tamil Nadu, Mukamika Institute of Medical Sciences, wants to know, when doing it, there are three questions she has. When doing a nationwide study or a study involving different geographic areas in the community, whom are we supposed to get the ethical clearance from?
See, if you are going to do a national study, there will be a national committee to actually approve it. Okay, say ICMR. So for COVID and all that, they had lots of projects like that. So task force studies. So initially that Central Ethics Committee of ICMR will probably give the first approval. And then the site ECs, whichever geographical area, whichever site you are going to run it, that institution's ethics committee also has to approve it.
He has answered this. Yeah. She also wants to know, is there any type of study where it is not necessary to take an ethical approval? I have heard that certain retrospective and classroom studies needn't get an ethical clearance, but I haven't seen it in writing.
It is there. It is there. It is there in the US common rules as well, in ICMR guidelines also. It comes under exempt. And it's not that it doesn't come to the ethics
What
committee.
is it? Okay. Now, is it ethically correct to collect data using online platforms like Google Form? Is it justified?
Yeah, but when you are actually submitting to the ethics committee, you have to actually submit the Google form also for the members to see that what are the contents of that Google form. Does it have any sensitive information or not? So they will decide about it.
Okay. Now, there are certain other questions. It relates also to vaccines. I'm not sure. Dr. Jain, Dr. Animesh is also there online. Any insights on ethics of vaccination for all?
That is actually a topic by itself, you know.
I know, and I think when we have Dr. Subhrojit Bhaumik, who is going to speak on vaccination as well as the development and administration of vaccines,
Yeah.
he
So
might
you
be
can
able
actually
to
pass
answer.
this question to him.
Yeah. Okay.
Not that I can't answer. If I answer, it will take long.
No, you can. You can. The only thing is you have a lot more questions in waiting.
No, the point is, yeah, that is there. Lots are there actually.
That's why I thought I'll give you some rest and shift some questions to Dr. Animesh. Are you there, Dr. Animesh? He's not there. Dr. Animesh Jain, are you there? No, he's not there. Okay, madam, then you will have to please answer this also, okay? Guidelines to do emergency IEC meeting to clear protocol. If there is any urgency like deadlines for submitting to ICMR, etc., in colleges where full IEC happens less frequently because of less protocols, like twice a year, how to overcome this is what.
So that is actually not emergency. It is an urgent need. So you can have unscheduled meeting.
Yeah.
Just you collect some proposals and then have an unscheduled meeting. Just for one proposal, it might be difficult. Now, because of the virtual platform, we are able to do that. But suppose in more normal times, it becomes a physical meeting, then all of the members will have to be mobilized, and that means a lot of expense. So you collect some proposals like that and then hold an unscheduled meeting, and there has to be a SOP for unscheduled meeting in the SOP list as well.
Thank you. How to implement in India, as people with hardly intent of ethical practices have infiltrated profession at all levels. Few only are ethical. Worst is they justify it and get away by all crooked means. From MIMS, Dr. Narendra asks. I don't know.
Anyway, ethics committee is there like a guard also, no? So you can't do away with ethics committee. The ethics committee will take care of that. But I do know there are several practices like that. Ethics committee is supposed to be independent, independently functioning. But I am also aware of the influence of the management as well. We are all humans, we get swayed. And there are vested interests which get pushed. That is there. And it's very, very difficult for upright people to function in such committees. And there have been instances where such members have resigned.
True. Vasundhara Tulasi from Apollo College of Nursing, Dr. Vasundhara is asking, is there any difference in structuring informed consent for children? How ethical is it to collect blood samples from children below 10 years for the sake of research purpose?
It is not a question of ethical requirement. It is a need. Is it necessary to draw blood? If it is necessary, you have to draw blood. And for children also, 0 to 7 age, the parents give the consent. Parents or LAR gives the consent. And from 7 to 12, it is oral assent. So what you have to submit to the ethics committee is a one-page, write-up on what questions you are going to ask. Because the ethics committee would like to know what are you going to ask. And for 12 to 18, it is written assent. Sorry, did I say consent? It's all assent for children. So, assent, if it is
I request the participants to kindly mute their microphone.
I'm muting
They've
them.
reached home and the pretty dogs are waiting. Okay.
I'm doing that.
Then Dr. Sudha has been asking a few questions. She says, we want to conduct a lot of investigator-initiated research, biomedical and health research, independent consultants, but independent IECs are not available or charge too much fee. Can you suggest a way forward?
Nandini ma'am, you're muted. Nandini ma'am, you're muted.
Nandini ma'am, you're muted.
I don't know how that happened.
The dogs barking.
The dogs barking muted me. Anyway, the point is that independent ethics committees do charge much more. That is true. But that is the only solace you can have. Otherwise, suppose you are a clinician, you want to do actually, and you are your own master, but you want to do research. So what do? You approach an institution where they have an ethics committee, ask them whether they will be willing to do. The ethics committee may say that if we accommodate you, there will be several others who will come to us. They can refuse also, but they can accept also. You have to try.
She also says, to her knowledge, that is to my knowledge in her language, to the best of my knowledge, you cannot obtain an IEC clearance retrospectively, she says.
Yes.
Okay. She also says, for conducting a study in a government-run PHC, what are the permissions to be obtained?
Yeah, PHC, you will have to take the health authorities of that state, their permission. Without that, you can't proceed. Any PHC. Government institutions, so permission from government authorities, health authorities, that has to be there.
Dr. Kailash Chandra says, for a new drug development trial, how benefit sharing will provide to the study participants? Is there any guideline on that?
Okay, so for drug development, if you're going to do drug development for commercial purposes, then it comes under the purview of the drug controller. Now, in the new drug and clinical trials rules 2019, it's given a post-trial access. Now, this post-trial access is one where your intervention has helped the patient. And there are no other alternatives available in the market. So that person would like to have that drug. I mean, benefit has been seen very clearly. So the investigator also has to certify that this will be beneficial for the participant if they can get it, if that person can get it. And for that, they have to appeal to the sponsor. And of course, they have to apply in a form. In that form, they will say that they will not hold the sponsor liable for any adverse event that may happen. See, during the period of the study, there may not have been any adverse event. That does not guarantee that you will not have it later also. So when during the period of study, the sponsor provides the money, compensation, okay. But outside the trial, why should the sponsor actually still bear that burden? So it is actually, they have to give a certificate stating that they will not hold the sponsor liable for any adverse event that happens. Either the patient writes or the patient's nominee writes that. And it is countersigned by the investigator.
Thank you very much, madam. There are, of course, many more questions. There would be, considering that we have circulated the registration form where people can put in their questions. We have a Zoom link where people have been putting their questions, and also YouTube from where we have been extracting. There are a lot of them, but some of them are repetitions of what you have already answered. And therefore, I know Dr. Sudha also has some more questions, but we would share all of your email details with all the participants and let them have the pleasure of getting their answers from the experts. Because I know it's been a long day, hard day.
Yeah. There's one question that I would like to answer, Sudha's question. Do we report SAE to DHR at least in future?
Yeah, actually,
DHR is involved in COVID problems right now. So the registration itself is taking too long. And the monitoring business is putting more fear in them. How will we manage that? Okay. So reporting to DHR is going to be quite long now from now. It may take 1 or 2 years more for that system to settle.
Yeah, I had that question again. I had to be unkind to her because we know it's been a long day and you have been doing it single-handedly. I thank you very much. I can see a question from Dr. Prashant who says, ethical clearance was obtained from an institution, but another institution, no. They pointed some problem that the other institution did not point out. What should I do? Maybe some of these are very specific to the researchers who may be involved with work in 2 institutions, working in one place, getting from another place.
So, multi-centric trial probably. So unless more clear details are there, I can't answer that. Yeah. And I would like to actually thank you all for the opportunity. It had been a pleasure, and I loved this actually. Virtually trying to tackle the questions and all that. So I was thinking the case study presentation would be a flop, but I think it was actually very enterprising in the sense that people were responding very quickly. That was quite interesting for me also. Otherwise, I would have lost interest. And I'm very, very sorry for coming late. I was thinking the program was at 2:30 by this thing. That's why I didn't have my lunch also in between.
Oh, I know that was in fact very sad that we didn't.
No, that's okay. That's okay. The thing is, I should be on time, so that's why I was a little flustered because of that. And then especially when VC is waiting and all that, I was very, very sorry about it.
No, not at all. No.
And also eating away with Animesh's time, but Animesh beautifully ended up in time. On time.
He's excellent.
Not at all. Not at all. Thank you so much. And I've been listening. I'm sorry. I was actually driving, ma'am. I couldn't take that question. I was at a busy junction.
I thought as much.
No, because the department started closing, so I could not. And today being the first day of unlock, people wanted to go. So.
Yeah. No, you will have them. You will be speaking tomorrow. I mean,
sure, yes.
So people will have, I think all the subjects are very interrelated and they will talk to you. Okay. So
yes, I just actually reached.
We don't have Dr. Nandini, which is why I think I was directing many of the questions because they only asked questions.
And she can single-handedly do that, ma'am. She's a mentor and guide for all of us. I mean, I've always learned so many things. Yeah.
Not that I'm also learning in the process, you see.
No, ma'am, you are humble. Definitely, of course, these, So, but then it's been really nice, listening to all those answers, whatever I could. So, yes.
No, this is where I think experience counts a lot. And I think having Dr. Nandini was really the icing on the cake for this program. So without much ado, I think, Anirban, are we okay to wind up?
Yes, ma'am. Thank you.
Okay, so on behalf of Nuksar, that is a research institute, and on my own behalf, you want to say something, Anirban? I thought I interrupted.
Yes, you only conclude.
You want to say something? Huh?
You conclude, ma'am. It's fine.
Okay. So, because our moderator has left for today, so I'm very happy that everyone who's registered, at least most of them, because others will get it on the YouTube, they have benefited And as I see from the compliments that are coming in large numbers, whether they ask a question or not, but everybody has been saying thanks, and everybody has been saying that it's been a wonderful session. So the beginning has been good. First day is always the difficult part of any event because you're getting set. And from from tomorrow, we expect it will be even smoother than today. And virtual meetings have really proved that distance or coming together has never made a big, I think, difference in the way we progress with whatever we want to deliver. And Dr. Nandini has very aptly said how she could connect to everyone, the very large numbers from many parts of the country, yes, but also from abroad. That is what amazes me, because we didn't call it international workshop, but social media allowed many people from outside also to be there. Some may specifically come from the talks that they are very interested in. So we hope that in the next 3 days, it will go on with the same tempo. If we could have Dr. Nandini again on the last day, at least for about 30 minutes during the final, I should say, not just Q&A session, but something like a panel discussion, it would be a pleasure. But if
actually, I would love to attend all the sessions, but tomorrow, same time, I have another program.
I know you've been very tight on time, you know. So
the day after, maybe I may be able to.
Yeah. So thank you, Dr. Animesh. Thank you, Dr. Nandini again. And we will sign off today with saying you have spent the best part of your time. Everyone's larynx must be very, very, I should say, exhausted. So we are not able to host you with good coffee or something. Okay. Thank you all. Thank you, Dr. Animesh. Okay.
Thank you, ma'am. Thank you.
Thank you, Dr. Animesh.
Yeah.
Thank you. Please share the questions, ma'am. In case there are some, we can always get back to and try to tackle them.
Sure. Definitely.
Yes,
Okay.
thank you.
Yeah.
Yes.
We will. Okay. Yeah.
All right.
Thank you. Yeah. Shall we sign up?